My name is Michelle Amana, and I work with the Stop-Ncd team as a health economist, and I'll be your moderator for today. Okay. Thank you. So before we start, I would like to invite Professor Ansah to pray for us.
Shall we pray? Shall we just rise for a minute and pray to our Father? We are thankful to you for the gift of life and for bringing us all here together safely. We do not take it for granted, and we say thank you. We ask, O God, that our discussions, our thoughts will be guided by you, so that we will have fruitful deliberations. And at the end, we will know that you have been with us. Cause us to achieve the expected end of this meeting in the name of Jesus. And we will be careful to give you the glory. In Jesus' name, we have prayed. Amen.
Amen. Amen. Amen. Thank you very much, Prof. So next, I would like to invite Professor Richard Adanu, the rector of Ghana College of Physicians and Surgeons, to give us a welcome address. Can you kindly give him a round of applause? Thank you.
Good morning to all of you, and welcome to this national stakeholder meeting. I think it's about, if I'm right, is it 2 years ago, so that we launched the Stop-Ncd project here at Malisa Hotel. We did that downstairs. So this is a project funded by the National Institute of Health and Care Research, UK, and it's a 5-country collaboration looking into non-communicable diseases and how we can, let's say, manage them in this part of the world. The project is housed at the Ghana College of Physicians and Surgeons, and we are happy to have this stakeholder consultation. There's been some work that's gone on in the first phase of the project, and I'm sure as you sit here in this meeting, you hear about what has happened in that. There'll be presentations, and forward. NCDs, as we know, is a very important thing in the world generally. And at meetings like this, I always say that many of us who come to these meetings who are in a certain social bracket, there's a chance that probably 80 to 90% of us, the thing that's going to kill us is a non-communicable disease. I mean, so there's also a selfish reason why we should all be interested in the research that goes on. Because if we know how to control this, well, we might live a few years longer. But if you're already tired of life and don't want to live that much longer, you could choose to ignore things about Stop-Ncd. But the truth is that all of us hang on to life, isn't it? However old you get, it's like, well, another day wouldn't be bad. Then when you get the other day, you say that, oh, this world is terrible. But we always want that other day. So non-communicable disease is a thing that we should all be interested in. Any research that's done in that should be supported by us. And we should kind of like see how we can control this in terms of behavioral change, in terms of treatments that happen in the hospital, and in terms of groundbreaking research that can help us control it. So we are happy to have people from different agencies in the health space in Ghana here with us. And I hope that we'll all pay attention to the presentations that are made and see how all of us together can join hands to make this project successful, but beyond the project, to make the the management of non-communicable diseases in Ghana, also a successful one. So I welcome you all to this and wish us all good deliberations. Thank you.
Thank you very much, Prof. So I'd like us to have a short introduction. So we just want to know each other here. So I'll start off from this table.
Yeah, good morning. My name is Dr. Eugene Bonzi. I'm an early career researcher with the Stop-Ncd team. How's that, GCPS?
Good morning. My name is Jejom Awalime. I'm the monitoring evaluation, and learning officer for the project.
I'm Dominic Anasba. I'm part of the research team. Thank you.
Good morning, everyone. I am Abdul Basit Abdul Samed. I'm a researcher with the Stop-Ncd project as well. Thank you.
Good morning. My name is Dr. Kezia Amatifio. I'm an early career researcher with the Stop-Ncd project.
Hello, good morning. I'm Nanefo Inimayawafun, and I'm also a researcher with the Stop-Ncd project.
Good morning. My name is Dr. Levi Najima. I wear two hats today. I'm with the WHO country office and also part of another project called Response, which we'll share insights about. Thank you.
Good morning. My name is Rosemond Iduopon. I'm representing the Registrar of the Pharmacy Council. I'm a pharmacist by profession.
Good morning. My name is Emmanuel Adu from Ministry of Health.
Good morning, everyone. My name is Dr. Pascal Kingsley Min. I work with WHO as a technical officer for non-communicable diseases.
Good morning. My name is Etonam Blende. I'm the Greater Accra Regional Mental Health Coordinator.
Good morning, Basil Kabori, Ghana for Epidemiology and Laboratory Training Program, School of Public Health, University of Ghana.
Good morning. My name is Angela Oguswansa. I serve as provost at Ashasi University. On this project, I serve as the principal investigator, and Ashasi is a subset of the Ghana team.
Hi, I'm Richard Adanu. I'm the rector of the Ghana College of Physicians and Surgeons.
Good morning. I'm Irene Japon, and I'm part of the Ghana College of Physicians and Surgeons on the Stop-Ncd.
Good morning. My name is Evelyn Ansan from Ghana College of Physicians and then UHAS, University of Health and Allied Sciences. And I'm a work package lead on the project.
Okay, good morning. I'm Aisha Kadiri English, a public health physician specialist. I'm representing the executive director of CHAG.
Good morning. My name is Dr. Salamatu Tokuma, Deputy Director, Information Monitoring and Evaluation with the PPMED Ghana Health Service. I'm representing the Director, PPMED.
Good morning. I'm Akuluku Samuel, First Vice President, Ghana Registered Nurses and Midwives Association. I'm representing the President of the association. Thank you.
Good morning. My name is Linda Yevu. I'm a qualitative researcher with the Stop-Ncd project. Thank you.
Good morning. My name is Emmanuel Opoku Asante, analyst with the National Health Insurance Authority.
Yeah, good morning. My name is Dr. Yao Opoku Boateng, Director Quality Assurance, NHIA, representing the CEO.
Thank you. Winfred Ofosu is my name, Regional Director, Eastern Region. Good morning.
Good morning. I'm Erasmus Agongo, President of the Ghana Public Health Association and associated with the Faculty of Public Health of the Ghana College of Physicians and Surgeons.
Good morning. My name is Dr. Rahina Ibrahim, Department Medical Center. Thank you.
Good morning. I am Godfrey Mbwakudiam. I'm a policy and research officer with the Ghana NCD Alliance, representing Mr. Labron Musa.
the National Coordinator for Ghana-NCD Alliance. Thank you.
Good morning. My name is Dan Taylor, and I work with Mind Freedom Ghana. Mind Freedom Ghana is an NGO whose work has to do with issues of mental health. Thank you.
Good morning. My name is Juliana Mankwamafo. I'm representing FDA. I'm with the narcotics section. Thank you.
Okay. Good morning. My name is Franklin Esiedi Bekwen. I'm Director of Public Health, Ghana Health Service.
Good morning. I'm Dr. Inshiraya Benwa, a researcher on the Stop-Ncd project. Thank you.
Good morning. My name is Ayo Hinedu, part of the Ashesi and Ghana team as a research intern.
Good morning. My name is Abna Waima Edise. I am a researcher on the Stop-Ncd project. Thank you.
Thank you very much. At least now we get to know each other. So next on the list is I would like to invite Professor Irene Ejapon, the project PI, to give an overview of the project and what we are here to do today. Can you kindly welcome her with a round of applause? Thank you. Slide.
So good morning again, and thank you all so much for honoring our invitation and coming. Yes. And also I convey the apologies of Dr. Sylviani, a member of our advisory committee. Unfortunately, because of problems with flights, she couldn't make it on time for this meeting. I'll just very briefly introduce what Stop-Ncd is and why we are having this meeting. And on this slide, I've just shown all the partners in Stop-Ncd, the Ghana College of Physicians and the London School of Hygiene. Thank you. Yeah, I've shown all the partners in Stop-Ncd on this slide. The Ghana College of Physicians and Surgeons and the London School of Hygiene and Tropical Medicine are the two institutions that co-lead this consortium. It is a consortium. And within and it's a West African consortium. Within the consortium, we have Ashesi University. We have LASDEL, a research institute in Niamey, Niger. And we have the Catholic University of West Africa, the campus in Bobo Dioulasso, Burkina Faso. And the reason is strategic. Next slide, please. Yeah. So next slide.
level, sorry, previous. Okay, thank you. Which national level policy actors are engaged in NCD control? What are their interests, their powers, their roles, and how do they influence NCD policy? We finally looked at which systems and policy interventions have strengthened and integrated NCD control in sub-Saharan Africa, and what evidence is there of its effectiveness. There are various methods we used in finding the answers to our questions. The first was we did a policy and stakeholder analysis. We looked at the NCD legislation policy, strategies and guidelines, and reviewed 14 documents. We also did an analysis of the content of the policy documents. We mapped out national level stakeholders and conducted 9 key informant interviews. We also conducted systematic and scoping reviews, which centered around diabetes, hypertension, and mental health in West Africa. So we looked at the factors that influence primary healthcare that's the access, quality, and control of primary healthcare for all the 3 conditions mentioned. We also looked at lifestyle interventions and their effectiveness in treating diabetes. And we finally looked at the impact of health system interventions for primary healthcare in diabetes and mental health related stigma. So there are several scoping reviews and systematic reviews published under these themes. We also conducted a quantitative survey, which is popularly known as the SARA survey, which is a service availability and readiness assessment that was developed by the WHO. We conducted this in 10 districts in Ghana, 4 from the Greater Accra region and 6 from the Eastern region. We also did a case study of the Gas South district. We did several in-depth interviews, observations of the community. We interacted with the various actors, that's the key actors in NCD control. We performed 2 transect walks and had focus group discussions with members of the community. So I'll hand over here for my colleague to continue with our policy findings.
Okay, thank you, Kezia, for setting the stage. So as Kezia said, we looked at health policy and system support for NCD prevention and control. And from analysis on policy documents and our engagement with stakeholders, it became evident that Ghana has made progress in the last 2 decades in terms of developing policies and guidelines, and also in the setting up establishment and institutions to be able to tackle NCDs. We also found out that Ghana had made a lot of progress in health system development to be able to tackle NCDs. So despite all the progress that we found, we also found that there are gaps in terms of the implementation of the policies and guidelines for NCD prevention and control. Some of them we identified to be gaps in financing for NCDs. We realized that the NCD, in terms of financing NCDs, there is no dedicated fund for NCDs, unlike other programs like the malaria control program, like the HIV program. NCDs do not have a dedicated fund. We also found out that the NCD control program, which is supposed to be the establishment that is supposed to anchor all NCD activities in our country, there is poor funding as far as their activities are concerned. They are not able to carry out, especially their preventive and health promotion activities to reduce risk reduction and treatment adherence. We also gathered that revenues that come from the syntax, which are supposed to be tailored for the prevention and control of NCDs, are often put in the consolidated fund. And we are not too clear how these revenues come or are given out for the implementation of NCD's activities. Then we also realize that most of NCD's activities in Ghana are donor-driven. There is no dedicated fund, as I mentioned, for NCDs. So most of them are program support-based, and these things are always the donor-driven. Apart from the financing gaps, we realize that there are also gaps in terms of our health information and data management systems. We are not able to generate enough data to be able to give good evidence of the situation of NCDs so as to be able to help us in our planning and also in coming out with interventions that will help to reduce the burden of NCDs. We found out that there are weak surveillance and research on NCDs, and this makes it difficult to track NCD trends and risk factors. We also found out that there is lack of real-time data for NCDs, and this also limits timely interventions and policy decisions, as I stated. Next slide, please. There are also gaps in terms of our human resource needs. We're both in the numbers and in the quality for handling or tackling NCDs. We realize that the NCD program, as I said, which is supposed to be the organization or institution that is supposed to take care of all NCDs activities in the country, does not have dedicated staff. Often they have to rely on experts from other institutions who have to play dual roles, and this does not often inure to the benefit of NCD prevention and control. Then also at the community or primary healthcare level, we realize that there are deficits in terms of human resource. Health staff are not adequately trained, and then we do not have enough of them to be able to provide NCD services at the primary healthcare level. Then also, we also identify some gaps in service delivery and collaboration for NCD prevention and control. Already we have issues or stockouts with service delivery in terms of essential medicines for NCDs, and then equipment for supporting NCD prevention and control at the primary healthcare level. And quite apart from that, we also have the issue of orthodox versus alternative medicine to grapple with. In many situations, as we found out, engaging with some of the patients, we realized, and even talking to some of the stakeholders, we realized that a good number of people are involved in primary health. People who are suffering from NCDs also undertake or use alternative medicine. And we are not sure when it comes to whilst the orthodox medicine or practitioners are preaching chronicity of the disease and management, the alternative medicine practitioners, on the other hand, are looking at preaching cure, which often puts our patients in a dilemma. We need to be able to address that, and my colleagues will be talking more on that. Then after looking at all the gaps, we try to also look at what can be done so as to be able to address all these things and ensure that NCDs get the best to be able to reduce the burden in terms of the disease in our country. So there is the need. We realize that there's the need for policy revision to improve NCD services at the primary healthcare level. We need to review our policy on service provision at the primary healthcare level to allow some health staff to diagnose, especially the PAs or physician's assistants, to diagnose and prescribe NCD medications, especially at the health centers and the chiefs level. There's also the need for us to review the essential medicine list, and then as well as the essential primary healthcare package service, essential primary healthcare service package, as well as the national health insurance benefit package to align with NCD needs at the primary healthcare level. We also thought that there is a need for us to promote integrated service for NCDs at the primary healthcare level. For instance, in situations where a patient presents comorbidities, maybe the patient comes to the facility with hypertension and some mental health conditions, we think that there is the need for some integration of service at that level to be able to get the same physician attending to the person to address his needs as far as his hypertension issues are concerned and also the mental health issues, instead of addressing one and allowing the patients to move to another place to go and seek care for the mental health condition. This often brings about the issues of stigma and also cost associated with referrals. Then on our concept of refill, we think that there's a need for us to review our concept of refill to allow patients to take up their medications from facilities that are closer to them, instead of going to faraway places like district hospital to access their medications. And on the wellness clinics, it was said that there is a need to expand it to strengthen early detection and management so as to reduce morbidity and mortality associated with NCDs. Then we also thought that there was the need to strengthen our health information and management and data management systems so as to be able to improve on our data capture at the national level, within facilities or across facilities, so as we can have a very good database of NCDs at the national level to be able to make decisions on that. Next slide, please. Yes, on financing mechanisms for NCDs, it was proposed that there's a need to emphasize on local resource mobilization and also to establish a dedicated fund purposely for NCDs, and also to use part of the proceeds from the syntax to fund this fund for NCDs. And then it was also proposed that there is a need to strengthen multi-sectoral collaboration so as to be able to bring all the players that are involved or all sectors that are involved in NCD, such as the Ministry of Health, the Ghana Education Service, Ministry of Finance, and all other sectors together to play a lead role in NCD prevention and control. Thank you very much for your attention. Now the next.
Thank you so much, Mr. Dominic. So I will continue with our systematic and scoping reviews. So we searched the literature from the internet, both published and unpublished research on hypertension, diabetes, and then mental health. We targeted the factors affecting care. And we actually came up with summary findings, which have been peer-reviewed and published in the British Medical Journal, the Public Library of Science, and then the Biomed Central. 3 of them are what have been published, but the last one is in writing currently. That's the stigmatization of mental health and its impact. Next slide. So on the summary findings, we've grouped them into enablers and barriers. Some of these findings are already known, but others were findings that we discovered with the scoping reviews. And we noticed that they are also complementary to the DEX reviews on the policy brief, the policy document. So on the enablers, we have well-established institutions. That's the National NCD Control Program, Mental Health Authority, and the Mental Health Department under the Ghana Health Service, and also National NCD Steering Committee, which enables the management of hypertension, diabetes, mental health. Also, as part of the scoping reviews, we noticed that research have found that there's high level of receptiveness and enthusiasm by health professionals toward the managing of NCDs, which is a plus for control. Also, there have been rollout of interventions that enable the detection and management, early detection and management of NCDs in the form of wellness clinics in our various hospitals. So especially in Ghana, you find a lot of wellness clinics in many of the hospitals. And when you come to barriers, many people have, in terms of the management of these 3 conditions, there's no one clear-cut option in the management. People do orthodox, people do traditional. So there are pluralistic medical systems and paradigms. There's poor adherence to the orthodox medication due to preference for herbal and alternative medicines. Now we'll see, as we are going through these slides, we should be making mental, because that will help us in our discussions during the co-production of the interventions. So we'll see where the gaps are in orthodox medications, also in herbal and alternative medicines. And then specifically for mental health, there's a lot of stigmatization. So that's a barrier in the management, stigmatization even at the level of the health professionals. And perceived side effects of medications is an issue for the management of conditions like hypertension and diabetes, where people prefer not to take their drugs or adhere because of the side effects. And many people also have difficulty in grasping that the conditions are lifelong and they need to continue to be on their medications for long. And also, this is not a condition where only the individual can support themselves alone. The community is needed, the household is needed. We notice there's weak household and community support. And as was presented in the policy document, there's poor policy implementation. There's a lot of gaps, especially with the national health insurance reimbursement. We'll move on to the next slide, which will now focus on interventions. These were systematic reviews of randomized control trials and some observation studies that we pulled together, registered in Prospero, and we also have submitted, it's been accepted for publication in the Public Library of Science. So this systematic review focused on the impact of health systems interventions in primary healthcare settings on type 2 diabetes. And we intended to do a meta-analysis, but because of the heterogeneity of the papers that we got, we grouped them into 3 teams, which makes it very simple. So 7 studies were grouped under the team 1, which was for individual and community support. So what interventions have been piloted or have been implemented, have been rolled out already for the empowering of patients. And team 2 will talk about what interventions have been rolled out in the health facilities. That's specifically primary healthcare. That's the CHIPS, the health centers, and then the district hospitals. And then the team 3 will talk about the systems and policy support, interventions that have been piloted and already rolled out. And then the other systematic review just focused on lifestyle interventions, which was on physical activities and then also on diet. So we move on to the next slide. So we've grouped them into 3 categories to make it simple. what was the intervention that was implemented, what outcomes was assessed. And with systematic reviews, we always have to look at the quality of the evidence out there to tell us whether we can go on with what has been already implemented elsewhere. And elsewhere we mean West Africa, because we wanted context-specific information. So Ghana, Burkina Faso, Nigeria, Mali, Guinea-Bissau, Sierra Leone, these were where we got the findings from. So the first team, what was implemented was education on lifestyle modification, which was rolled out in 4 weeks interventions, 6 months interventions in some of these papers. Also self-management education, and then education on chronic care. And the outcomes that were assessed were the outcomes of interest. That's glycemic control, health literacy, and then also on prevention and adherence. And we noticed that all these were improved when these interventions were piloted and then implemented. And these studies were in Mali and Nigeria. And we used what we call the grading recommendation assessment, development, and evaluation tool to check the quality of evidence. And when we say high quality, it means that there is no need for further research in such areas to change the effect size of what we have. If we say moderate quality, it means that there could be some changes if we try to do a new research there. So we'll have to look at the limitations in those papers and then try to do new research in there. And then when it's low quality, it means that there will be a drastic change if we are to do a new research in there. This intervention had moderate quality. The next slide. And the next was on the facility support. What was implemented was training of providers. So interventions where providers, nurses, doctors, pharmacists were trained in the management of type 2 diabetes, also formation of diabetes-specific teams within the hospital. So instead of just an internal medicine team, we have specific diabetes teams, which has the nutritionist, the doctor, the nurse, the psychologist. When these were piloted, also electronic information sharing, and also what we call tax sharing, where you have the shift of tax from prescribers to other non-prescribers so that they can manage diabetes. So not just doctors managing diabetes, but also physician assistants. Physician assistants are prescribers, but nurses, pharmacists were also able to manage the conditions of diabetes. And previous slide, please. And then the outcomes that were assessed were also on glycemic control. Previous slide. Glycemic control, and previous slide. A glycemic control, adherence, and then responsiveness from highest level stakeholders. And this, previous slide, please. And this was also of moderate quality. And next slide. The next slide was still on facility supports. This was, the sub-team here was on organizational culture. How is work done in the facilities? And one of the interventions was increasing the provider-patient contact time, how long the doctors or the PAs will spend with the patient. Also collaboration between stakeholders for lesson learning. So collaboration between different level stakeholders at the level of the patients, at the level of the directors at the hospitals, also at the national level, and then also establishing patient groups. These are all interventions that people have tested already. They've been piloted, and the outcomes that were assessed was improved glycemic control, increased adherence, and increased responsiveness from the higher level stakeholders. And using the grid, we had high quality of evidence from these interventions. Next slide. And the third, which was health systems and policy support, this particular intervention has been already implemented in Ghana. So we just recorded them. That's setting up of diabetes clinics within health facilities. We already have diabetes clinics in most of our health facilities. And also supply of equipment and materials for diagnosis and treatment. The other one, health insurance reform, was piloted in studies in Nigeria. And the outcomes assessed was improved adherence to treatment and appointment schedules, improved glycemic control, and then financial risk protection. This study showed low quality of evidence. Then we move on to the effectiveness of lifestyle interventions. We conducted meta-analysis of lifestyle interventions, that's physical activities and diet. So these were structured physical activity programs, including aerobic exercises, low and moderate intensity exercises, walking for 30 minutes per day. These programs were tested, and we did a meta-analysis of 10 studies, and the pooled effect size for HbA1c reduction on both lifestyle and diets including fiber diet, calorie-restricted diets, was 1.89, which showed improvement in HbA1c. And this was we used just the Cochrane Risks of Bias tool, which is a tool that is used to test for quality of randomized control trials. And we saw high quality from these studies. These studies are from Ghana, Nigeria, and Mali. And this is where I would end, and then the next presenter would come in. We also have one study on hypertension, which is about risk assessment using AI. I will not go so much into details about it. And the presenter on hypertension will come, and then we'll talk more about the risk assessment tool for artificial intelligence. But then on the interventions that have been rolled out for hypertension, we already had literature reviews and then systematic reviews that had been conducted. So we didn't go ahead to do new systematic reviews, and 2 of them were very recent, from 2023 and then 2022. And the interventions are similar. Next slide. The interventions are similar to what was found in the diabetes, so I wouldn't go so much into the patient education, health workers, organizational culture, all with the outcomes of improved adherence, early detection, improved BP control. So this is where I'll end, and then the next presenter will come. Thank you.
Thank you, Eugene, for your presentation. So the next presentation will be looking at our results from our quantitative study. And basically, we adopted the WHO Service Availability and Readiness Assessment tool. So this tool is a health systems resilience tool that can be used for various health conditions to basically look at the readiness of these facilities to be able to cater for the needs of these particular health conditions, and also whether there are certain basic amenities which are available within these facilities to take care of these conditions. So what we did was a cross-sectional study, and we used the WHO, we adapted the WHO SARA tool for this. So we conducted this in 10 districts across Greater Accra and Eastern Region. And the reason for this is to get a mix of both urbanized and rural districts, so that we can get a good representation of the situation across the country. Okay, so these are the list of the districts that we visited. So in total, we visited 210 health facilities across these 2 regions in these 10 districts that we visited. Next slide, please. So this is a spot map that shows where the facilities are clustered around. So Greater Accra is the red region, and Eastern Region is the green region. And as you can see, we went all the way to the northern part of the Eastern Region, and this is the Kwewu Afram Plains district. And also in Greater Accra, we had facilities which are around the urbanized part of Accra, and also around the rural part of Accra, which is the Ada East district. Next slide, please. So these are the types of facilities, the percentages of the types of facilities that we visited. And we went across all the primary healthcare facility levels. So right from the district hospital level all the way to the CHIPS level. And obviously, the CHIPS facilities were dominant. There were over 55% of the facilities visited were CHIPS. Next slide. So for the regional breakdown, we noticed that in the Eastern region, the CHIPS facilities were dominant. There were 72% of all the facilities were CHIPS in Eastern region. In Greater Accra, the picture is a little bit different. We have virtually the district hospital level, polyclinics and clinics and CHIPS almost around the same percentages. But however, the health center seems to dominate in the Greater Accra region. Next slide, please. And also we looked at the managing authority within these regions. In Greater Accra, the assessment that we did not just limit it to public facilities. However, private facilities were also included because they are an essential bit of health service provision within the country. And in Greater Accra, we found that 60% of the facilities that we visited were actually private facilities. And in the Eastern region, we found 2% mission facilities in the Eastern region. Next slide. So then we go now into the assessment of the tool itself. So the tool basically has two components, which has to do with the service availability scores. So the service availability scores has to do with whether that facility can provide services in relation to that particular condition. So in relation to hypertension, all the district hospitals that were visited can be able to diagnose and manage hypertensive conditions. The polyclinics, 92% of the polyclinics visited could offer these services. However, it was curious to find that when we go lower down the primary health care levels, at the health center levels and at the CHIPS level, we noticed that there was a higher percentage of management to diagnosis. And clearly, this gives us an indication that though currently the policy is for the management and diagnosis to be centered at the higher level primary care facility, that's the district hospital and some polyclinics and clinics. The situation on the ground is actually showing that due to challenges with especially financial and geographical challenges in some of our communities, there seems to be some provision of care even at the lower levels. So management of, especially in relation to hypertension, was higher than the diagnosis within these levels. Next slide, please. For diabetes, we found similar results, also having higher management scores than diagnosis scores. Next slide. For mental health, the situation was a little bit different. As we go down the primary healthcare levels, we realize that the percentages fall from 100% within the district hospitals who can provide diagnosis and management of these conditions. It falls to 67%, 66% at the health center level, then around 5% at the CHIPS level. Okay, so the next domain of this assessment tool has to do with service readiness scores. And service readiness scores has to do with the basic equipment that these facilities have in order to care for clients. It has also to do with basic amenities and other domains. So from the results, what we notice is that for the basic equipment scores, okay, let me start with the basic amenities scores. With the basic amenities scores, we realize that as expected from the district hospital level, which normally you will find them in the district capitals, they normally have access to basic amenities in relation to access to electricity, water, and other basic amenities. And as you go down the health, the basic primary health care levels, the access to basic amenities actually reduces. Now, when we come to the basic equipment scores, there was a little bit of variation in the results. Having in the district hospitals, there was 65% of the basic equipment scores. So what the tool does is that it has a list of equipment that these facilities are supposed to have. But then out of this list of facilities, for these different levels, what percentage of these facilities are existent? Okay, next slide, please. So for the basic equipment scores, we decided to do a disaggregation to look at the Eastern region and the Greater Accra region. And when we did the disaggregation for the district hospitals, in Eastern region, they had 100% of the scores. And as expected, as we go down the primary healthcare levels, the percentages reduce. But in Greater Accra, there was a mix of results in the Greater Accra region. And we saw a dominance in the health center level. And some of the explanations that we have found is that sometimes there is a lot of donations from NGOs and other organizations providing equipment at some of the lower level facilities. For example, one of the facilities that we visited, they had a donation of a modern autoclave. However, they did not know how to use the autoclave. So the autoclave, brand new in storage, but then not in use at that level. Next slide. Okay, so we also look at the diagnosis capacity scores. And in the diagnostics capacity scores, we found out, as expected, at the district hospital levels, their diagnosis, even though it was not optimal, but they had the highest scores at 84%. And for essential medicines, this was curious to find that out of all the essential medicines that were listed, that we were actually validating to know if they exist within these facilities, all the levels scored less than 60% of the essential medications that they are that we were assessing for. Okay, next slide. So this is a heat map trying to measure the distance between a referral facility and lower level facilities. And here, the referral facilities will be the hospital facilities, which has the red plus sign. And in the Greater Accra region, in the more urbanized areas, you realize that there was a lot of clustering of higher level facilities. And the lower level facilities, that's the clinics and the CHIPS, were within a 5-kilometer radius, easy to access these referral facilities. But when we move to the Adan East, please, previous slide. Yes. In Adan East, we realize that the situation becomes a little bit different, where the radius, the referral distances now expands from the lower level facilities to the referral facility. Next slide. So in the Eastern region, this situation becomes more prominent, where we have very few referral facilities and a clustering of many lower level facilities. When we look at especially the Afram Plains North District, there is essentially one referral facility here and a lot of lower level facilities. And some of these facilities have to traverse over both river and land to get to the referral facilities. And we are recording NCD cases across all these facilities, whether higher level or lower level facilities. So access to care is actually a problem that we need to really look at. Next slide. So this will be the end of my presentation.
presentation. So before I move into my presentation. There's a video we recorded with a patient living with diabetes and hypertension in Adan East. She shares her lived experiences and all the information she talks about cuts across what Eugene has found in the literature, in the policy, and in J. Jones' work. My name is Linda Lucy Hebrew. I'm a medical anthropologist. And before the video rolls, the woman is okay with showing her face. We took ethics, we went through ethic approval with her, and she wanted to be an advocate for NCD patients. So enjoy. The issues, we are not politicians. That music was selected by her. We guided the community, the woman and her relatives to shoot the video. We only helped her to edit. They chose the theme, the music, and the story to tell. Thank you.
Ouch! Palutaye, esken palutaye. Goye mama, ready goye mama. Can't jane wapa, ready goye mama. Yeah, boy sit kope, orati unya iseke. Therefore I am fanchiche, therefore I am fanchiche. Mama koma nyamiya, kapa my baby yamiya. I am it do, hot dog baby yamiya. I am it do.
They can say one diabetes in India, and now BP are in India. I want to have this new doctor. Doctor, the mobile system. Now, a radin ever man, you're not through money. The doctor don't know it. Just say, you say, Ubay, yes, men do it. Now, so sudden, a dog who beddy peche. One say, wow. Yes, men did bunch, men did bunch. But then, so that they are near the abbey, the embryo, and all the bell of food. To not buy a broadly and name now, Betty. And yet, Johnny be I can say, well, you do near my started when you can say, what you mean. And I am more a looker on a doctor say, but told me then I did outside the bar, won't you mean. Would this Nemanema, who come out, as I would do so. Those I was a conqueror. Who are diabetes? I know my soul bed. A cake says, a media, as if by coming Chamumi and son. Chamumi and son, as if for any nurse. Say, I'm quite so nurse. Now, we didn't cut out to me dinning in a boom back. My try here, my dibino. And here is a cry. Let me home it. Me home it. Me bewu. Until someone that the doctor Becca say, yeah, no, or no, obey. Do not dear, me fan, if you know, a child send them to say, son, obey no. We say, Anopa, if I back when there, this are the chief and son of a sanfa. If you are no so many no, who for me, no, and there, and you must me, no. Funny, I may warn. Yes, you go back one or the best Uber changing. So I am in quantity. The was a pushing me for. Let me decide. It's a funny boy. First in and Jessica be a. This is a bit who got to a 5 city. Intimate by a four. Intimate the was a none said the amount tough for me, Tommy, you know, fair 10 city. And I made the water sister to be a meeting home. The hospital, I acquire Sika bakery. Now say when you go in a 1.7 and I say I had to send I had my dear. If you need that, maybe Katamani, many the house and I dear Betty. They will say, dear me, drinking us. I would not mean to say that man, no, I do not. Now, I just be all yari da. I bet you baby put, you see me got to test it. Na na me test says si ni wo hi say man ko to bibia basa na me ya haban kaka de ka na aban na ma si na ba ka no bitalivu mi pusasa e be fa hu to say samuna na ma soni so ka bu ma na kpan na ma bitalivu e chire mi ma wa ya bi so ba chire ma wa haban we na hu su ba em premier no na ma nua minuma oh junso we na junso sa mi da mi na kaka na ma so ya junso na ye se ehu mi moja mu doctor do mi nu fomu de mi nu e be du be bia we kube a wo so uti kube na o de we akatwe de achima gumu onu so nu ma e be ma esije na ba fo ni brother akota asi abedu me chen ana mi si oh asiki omi na water bra na se obibia na o baba yi o mi kama no hwe na ye de we nkati e wo mu o di asiki na wi nkati e o di asiki na wi ani asem kitu o mi ti ade be chi no na si fo na be pai mi ba mi se da dente akota asiki ba tu me chen na si che na sa ko trokra mi sa se ye yi mai bubu ahun di ye yi mi no o ade be chi na ye yi ye be yi mi no na ya kire mi panie no wo mi wo ne say be wo ne say e te de mi wo mi nsa te de mi wo wa ha de bia o pe bia o be wo ye si mi ye fu ke meti na wo so mi tra be ye mi wa na e ho ne kika na mi ye fu no so kika si mi wo mo mi eno ase po mi frɛ mi nua ketewa bi na chi ba na maka cha se me ko hospital ti eno a de do wa yes ya wa se ni 3 million na me de be ko hospital brother ti omu na mo kwa me kaka mi ti ase be se de mi pun de wa ka bebi be ye enfie nso mu na ye wo yi ni kwala mu kaka na wo omu na e kaka ye ti ho edo na ebe ma nsola sa cover ha enso ka obetua no enye ka ketuwa ye nya bi wo ho ma na se tro se koto e wa hia ma na sugar copy be kwa to koto be 1.3 edo ba enso ye ma wo hospital dia na eye kakra ti ya asaban be boa ya onwa ye yarefo no na ye hu toye ye bre ye titi
Thank you for your attention. So basically, she has summarized all the issues that we've mentioned, we've talked about. We conducted a case study in Gas South, and then to be able to do our co-production, we went to present the findings from Gas South at Adan East for them to validate that what we found, is it different or there are similarity or differences? And that is how come we have this information from the woman in the Dan. So I'll just go on to the findings. The findings, we look at interventions at the facility level, community level, and then individual factors and support systems that enable or serve as barrier to NCD control. We did the studies, Eugene, J-Jom, all of them, they were done separately. But at the end of the day, we found that most of the issues were cross-cutting. They were similar. There were no different, they couldn't find lots of differences. At Gan South facility, we found out that they have a wellness clinic where they screen for hypertension and diabetes, but none for mental health. So because BP apparatus is present, they screen all of them. when it comes to diabetes, because the clients have to pay for the test strips, it becomes a challenge. All right, they said it's too expensive for them, 10 cedis, they can't do that. And then there's also a health promotion unit in the facility, and then they go around the community to screen for hypertension. And one of the issues they mentioned was the non-availability of high BP apparatus. So they decide not to do it. But at the facility level, you can get that, you are screened for that. And there's also services days for NCDs, hypertension and diabetes. The other mental health is a regular kind of thing to do. If you come there and you report that you have a mental health condition, then they attend to you. But these provisions are done in silos separately. Unless you complain that you have issues, then they would refer you to the mental health clinic. And also there's the OPD, the healthcare providers, they liaise with the eye clinic. And so from time to time, they ask the client to go to the eye clinic to screen for their eye. They are strategic. The health insurance covers, okay, for a day, a month, you could come to the facility with 2 conditions. If there's a 3rd condition, they'll wait. When you come to your next visit, they'll say, okay, today I've seen you for hypertension. Go to the eye clinic. Then they can reclaim the services they rendered. But if they are giving you the 3 at a go or 4, then there's a problem. So they have devised a way as street level bureaucrats to ensure that these services are available to the clients and when they need them. Then there's also collaboration between them and other NGOs. So you see, Mind Freedom is one of them, and we are happy that they are here. They help them with mental health issues, supporting them at the end of the day, anything that the clients and their relatives need, social support or logistic support. Some of the healthcare providers are also advocates for the clients. So they are healthcare providers, but they advocate for the client's well-being. And then they also liaise with the media for health promotion activities free of charge. Okay. But we found that, like Eugene mentioned, and Dominic has also mentioned, and the GJOM, there are a lot of issues about the interventions being on their own. They do not collaborate. Also, there were implementation challenges when it comes to medicines availability because of reimbursement issues. Clients, they would have to, normally in the past, they used to give them 3 months of drugs for 3 months, but because of reimbursement issues, they will say, I'll give you 1 month. If you want the drugs to cover for 3 months, then you have to pay. Health insurance will only cover 1 month. If you want 3 months because you don't want to come back so many times, they will say then you have to pay an extra cost to be able to get a 3 months of your medication. And that is a challenge for the clients because some of them lived far away and coming back to the facility every month was an issue and it affected adherence. There's also the issue of infrastructure issues and other resources like logistics, glucometers, test strips, BP apparatus, which is a challenge. And some of them have devised a way to, for BP apparatus, some of the healthcare providers brought their own BP apparatus to be able to measure their BPs of their clients. I'll not read through all of them, but they kind of buttress what the other presenters have talked about already. Then there's also referral challenges, especially for mental health clients. And when it's getting to the severe form and they think that they needed support from the psychiatric facilities, then referring them to them, they'll say the psychiatric facility will say, hold on, hold the person, we treat you how to manage. And sometimes they are kind of, we want to let this person go to get better care, But if you're asking to keep the person, then they become frustrated and do not know what to do. And then dietitians are not present, are not supposed to be at the district level. So we have nutritionists, and then the nutritionists are also worried that they can only give a general overview of what they are supposed to, the client should do, but going into specifics, and which the clients always do not want to go for a referral. So they are already concerned that I can give a general overview that, okay, eat banana, eat this, don't eat this, but going down, narrowing down to okay, this portion or that portion, they are not too sure what to do. And so they were talking about, we need support. If anybody can come, then dietitian can come even once a week or a month to support us. It's a way to manage their work. And then, so at the community level, like the woman talked about, people think diabetes, hypertension, and mental health are caused by evil people or witchcraft. And so the first thing, if they have a family history, they accept. But if they do not have a family history, the first thing is denial. They'll say it doesn't exist, it's not true. That can't be true. It's the devil who's attacking me, or it's a friend who is attacking me. And this takes a long time for them to accept management. And then in the facility community, they perceive that because of the way alternative healthcare providers deal with them on a personal level, and they can rap, all right? They can talk well and can convince them. They always are telling them they have a cure and they have a cure, they have a cure. So for the clients to hear at the facility level that you have to live with it for the rest of your life, and then the alternative healthcare provider says, I can cure you, it becomes they are in a dilemma. What do we do? Is it true or not? And when we go to their phone, then I ask questions. Is it true? It's not true. We really do not have answers for them because we know what the answer is. And sometimes they perceive that the herbal medications do not have side effects, but the orthodox medicines have side effects. So as soon as the alternative healthcare provider gives a little bit of convincing, they are sure to follow them. Okay, so Basit will continue with the alternative healthcare providers issues. Thank you.
Okay. Thank you very much, Dr. Lucy. Good morning once again, distinguished guests and colleagues. I am Abdul Basit Abdul Samed, and I'll be presenting on our work regarding aligning alternative medicine with the primary healthcare system. Now, before I start, I would like to take us to South, where a grandmother living with diabetes faced a difficult choice: to have her leg amputated or risk death. She chose neither, and instead she decided to combine her hospital medications with her herbal remedies, and today she walks. This could be an isolated case. However, as we reflect on the video we watched earlier, we begin to see how these deep-seated issues resonate amongst our people. Now, going into this research, I was a bit skeptical given my background as a physician. But as we engaged patients, herbalists, medical providers as well, and also policy actors, we discovered some quite interesting findings. And first of all, to start off, it would interest you to know that we have about 55 herbal units integrated into various hospitals in Ghana. And this doesn't just represent a number, it actually represents a foundation from which we can build a more inclusive and effective healthcare system. So now let's go into the real issue, where we would be looking at the patient's journeys. Now, to take you through this, first of all, we have to understand that a lot of patient agency comes into play when we talk about how patients navigate between the alternative system and then the orthodox system of care. So patients usually start their journey in the setting of a critical health situation. It could be the diagnosis of a chronic condition or an acute emergency. Now, patients don't merely choose between the orthodox or the alternative systems, just merely based on choice. This is actually strongly influenced by the need to survive and live beyond what we might classify as a concluding stage of their lives. So this particular stage is influenced by a number of factors. So we would look at how, first of all, the financial realities play a very key role here. So we notice that when orthodox medications become very expensive, patients don't just abandon their care. They actually seek alternatives. Now, as they navigate between the alternative and then the modern healthcare systems, they learn strategies to actually make things work for them in a way. So we had situations where patients, for example, told us that they take their hypertension medications in the mornings and then they take their herbal treatments at night. So as the patients walk through these, or they progress through these situations and the conditions evolve, we realize that they become astute observers of their own healthcare. And in this case, they are able to adjust their treatments based on how they feel or what their bodies tell them. Now, it's also important to note that this is very deeply ingrained in the cultural beliefs about health and wellness. And beyond this, we also discovered that various support systems help them navigate between the orthodox and then the alternative healthcare spaces. So as we have discussed so far, or found out so far, it may seem that this is a remarkable instance of patient innovation. However, the concern here is that this micro-integration, as we will call it, is happening without the needed guidance from professionals. So from our research, we discovered quite a number of gaps, and the key ones that we'll look at here is the issue of the mistrust and communication barriers. So in honesty, we have two elephants in the room. We have the traditional, the alternative medicine providers, as well as the orthodox system. And what we found out is that there are deep-seated mistrust, like issues around mistrust amongst these two systems. So the question now is that how do we make the two elephants work together? So we found out that on one hand, the alternative providers actually feel undervalued by the orthodox care providers. And on the other hand, the providers in the orthodox system actually have deep doubts about the safety and efficacy of the herbal products or treatments. So the question now here is, who is caught in the middle? It's obviously the patients. So in this case, it actually hinders open communication between patients and providers. And we also sadly realize that patients are not able to get the needed guidance to have good health outcomes. So moving on, the next issue has to do with the regulations and standards, because we found out that we are actually lagging in standards and protocols for integration. Even though we do have a national traditional medicine policy, there needs to be a lot of work regarding this to make sure that integration is as effective as it can be. Now, the last one regarding the access barriers, we found out that the very first issue I spoke about regarding financial realities played a very key role in how patients sought care in one way or the other. So we realized that financial constraints actually lead patients to make some risky choices. And it would be of interest to know that patients use suggestions or healthcare suggestions from platforms like TikTok, because we had a patient who spoke about how she is learning how to control her blood pressure by taking Sprite. Yes, the soft drink Sprite. And this is actually something we found, we didn't create this. So it's actually concerning. Now, we may be wondering if Coke might also help with sugar control, but well, that's the situation we find ourselves in now. So moving on from this, compounding this challenge is the fact that validated herbal medicines are not covered by health insurance. And this is also a very key issue that we will later on address. Yeah. All right, so we'll go on to our critical needs and then our suggested recommendations. So to address these challenges, we highlight critical needs and we suggest some recommendations for action. So first of all, we need to bring the two elephants together to work together. And this is obviously going to be perhaps a very big task to achieve, but then we can start with gaining common trust and understanding. And this can be done through, for example, establishing professional learning networks between the two systems, where alternative and orthodox providers can come together, share knowledge, build trust, and even go on to establish standardized documentation systems. For example, for reporting adverse events when patients combine treatments from both systems. And in the long run, this will help us to improve or enhance safety monitoring and ensure accountability across both systems. Now, the next need is with regards to quality assurance. So there needs to be a strengthening of testing facilities and capabilities. And this is crucial to ensuring that the safety and efficacy of alternative medicines and treatments are actually assured. Okay, so to the very last point where we would make quite a number of recommendations is that distinguished stakeholders, patients should not have to move between the two systems in silence and alone. The issue here is that they should receive continuous care and support and throughout their healthcare journey, especially for non-communicable diseases. We can look into enhancing referral systems between the two systems and also making sure that care is well coordinated. Furthermore, we need to look at launching targeted campaigns to inform the public about integrated healthcare facilities across the country. Because honestly, until I got into this research, I didn't actually know about the 55 herbal units integrated in the various facilities, and it was quite a worry to me. Then going on, we can implement community outreach programs which target unsafe practices to mitigate the risk of associated self-medication, because at the end of it all, it's actually the patient we care about and the patient who matters. And last, we need to start looking at piloting national health insurance coverage for validated alternative medicines to make treatments more accessible while ensuring they meet the needed standards. So in effect, integration is already happening. Now, the question before us today is how to do so safely and effectively. Now, as my colleague in the next presentation we'll be talking about regarding co-production, transformation will require all of us to work together. Thank you very much.
Thank you to all my colleagues. So this will be the last presentation, and we're hoping it has been interesting and insightful enough that you've not realized how long you've been sitting. So I'll be talking about the co-production of interventions. And I'm sure you've all heard this adage that goes, "Mina mitimi jim na minim sene ehyehyɛ mefa," which loosely translates to say, "He who sits in the fire knows how it burns." And the idea behind co-production is for researchers to sit with stakeholders who are involved in whatever condition they are going through to be able to come up with some contextually relevant interventions that are beneficial to them. So next slide, please. So in the context of Stop-Ncd projects, our aims are to co-produce interventions for the prevention, the diagnosis, and the management of NCDs. And we are specifically talking about 3 NCDs, which are hypertension, diabetes, and mental health conditions, common mental health conditions. We hope to do this at the community, facility, and systems support levels in Ghana. And at the end of it all, we would like to conduct a formative process evaluation of what we have done. Next slide, please. Next. So we did our co-production in the Greater Accra region in Ghana South and Adan East districts. And then we also went to the Eastern region where we went to the Kwewu Afram Plains. And the levels of co-production has been at the national, regional, district, and facility level, as well as the community level. And we're hoping that all the ideas come together to give us some contextually relevant interventions. Next slide, please. So at the various levels, at the regional level, these are some of the teams that we engaged. And at the district level, we had the district director, district health management, and heads of facilities. We went to the regional level, which is the Greater Accra Regional Health Management Team. Facility level, we saw the frontline workers, those involved in healthcare. At the community level, we went to the people living with their conditions, their family members who are usually neglected. We went to the chiefs and the elders, community volunteers, community nurses. We went to traditional practitioners as well. So they all came together into various forums to discuss some possible interventions. So the next slide just shows some pictures of some of the forums that we've had at the various levels. Next. So I'm going directly to talk about the possible interventions that were suggested by our various stakeholders. We've tried to divide them into themes. So we have enabling healthy life. These are interventions that have to do with enabling healthy lives. And there were suggestions about interventions on health, education, on dietary lifestyle. Some stakeholders suggested picture guides, education at the OPD, using media channels. There was suggestions about education of religious and community leaders about the management and prevention of the NCDs, empowering patients and families with self-management knowledge. And then there were some suggestions about screening in various community areas, the schools, churches, markets, community centers, including co-screening of all the entities that we are talking about in the communities and facilities. And there were also suggestions about peer support, forming social support clubs in the communities for those who live with these conditions. We also had the theme of improving access to or utilization of primary care facilities and medicine. So there were some interventions suggested regarding enhancing community-based screening and referrals by building the capacity of community pharmacies, chemical sellers, community health workers, and volunteers, strengthening the community wellness clinics, which already exist, but sometimes are not working too effectively. And then there were interventions around proper training and licensing for herbal treatment providers, as well as forming alliances between physicians and traditional healers for easy referrals. Interventions were suggested around increasing the availability of essential medicines and also, of essential supplies, and also including medical officers in the community outreaches so that they would join the community health volunteers and nurses for diagnosis and management purposes. There were also interventions around policy reform, so including reviewing of policies and guidelines to include diagnosis by health centers and CHIPs, and engaging the NHI to include essential drugs at health centers for all the conditions. Finally, there were also interventions suggested regarding regular staff appraisal adding medical officers to the committee teams, as was already said. There was suggestions around tax shifting by equipping and training nurses, providing specialized health professionals and facilities, reinforcing the education of healthcare workers, and providing motorbikes and bicycles for community health workers. Next slide, please. So the idea behind coming up with possible interventions is to look at what we have gathered from our primary data collection, our literature review, which is the scoping and systematic views, as well as the co-production forums, which is the 3 methods that we have used. But in doing this, we realized that there are policy implications that need to be considered. There are contextual and financial resource issues that need to be considered, and there needs to be stakeholder engagement for there to be some effective interventions. So this final slide is to show some of the cross-cutting themes across the various methods we use. So when we went into the literature, when we went to talk to the communities, the facilities, the stakeholders, and when we went through the co-production forums, we found 4 cross-cutting themes. There were interventions suggested regarding patients' educational and empowerment interventions. Secondly, tax shifting and access to specialized health workers. Third, the access to care and medication at lower level facilities. And finally, screening and integrated services for all 3 NCDs. So these are the findings that we have come up with. And the floor is now open for questions and discussions. Any questions that you have about any of the presentations, any suggestions, anything you want to discuss, the floor is open. So I'll call on the moderator to take the session. Thank you.
Thank you very much, Nanefua. I think they deserve another round of applause. It's quite insightful. So as she mentioned, the floor is now open for any clarification, any questions. So kindly show by hand and we'll bring the mic to you. Okay. Yeah. So Prof is going to.
All right. I think, Prof, you had your hand up.
I'm going. Right. Thank you for that presentation. You guys have really done great work. And you've, at least if you've not educated anybody, you educated me a bit this morning. My question is about the co-production. When you mentioned the co-production, I thought it's, especially with the bucket model that was there, I thought it was bringing the different people together for them to talk and then come out with an idea of interventions. But it sounded like it was, at least what I got looked like, it was you, the researchers, talking to the different people and coming out with something. Did I miss something? I just need some clarification on that. Thank you.
Thank you for the question, Prof. So yes, that's how we started off. So we went to the different stakeholders at the different levels, community on its own, facility on its own, district on its own, and the regional level. And my colleagues can help me if I leave something out. So the idea was to allow people to be able to talk without feeling as if there was some maybe power issues where they didn't feel comfortable enough to talk at that level. We thought that we should get everybody's opinion at the various levels. I think it is part of the exercise we are doing here to think through, is it, it's questions have come up if maybe we should consider bringing all the stakeholders together. So it's part of the discussions that we are here to have.
If I can help a bit, you are right that co-production is designing the solutions with the stakeholders, but we've been using a process of first almost validating with the stakeholders. Now, is this right? Are we off? And if it is right, what ideas might there be to resolve the problem? Then the next stage will now be within these ideas, which of them Actually, we know what to do. We are just not doing it. Which of them do we really need research to help us move along? And I think today's forum is the first stage in the now. Let's find solutions together. And that's why in this forum, we are bringing together all that has been found. So you are right. We are not done with co-production. Yeah.
With your permission, I think one of the points that Linda raised is definitely a thing that I would suggest that the group thinks about, the whole power differential when you bring everybody together. I mean, doctors and the big chips that we have on our shoulders, we like to dominate all kinds of conversations. And somebody talks, we have the look on our face that, I mean, this really doesn't make sense, and the person doesn't talk again. So it might be good for the group to grapple with the issue of what's the way by which you can bring all these people together and you can control the intimidation and all those things. Because at the end, you might have brought them all together, but the conclusion will be what the loudest voice wants. I mean, I don't have solutions to that, but it just popped into my mind when you said that. Thank you.
Okay, thank you so much. Kindly permit me to sit.
Can you please follow my direction on who to give the mic to? Please go ahead.
Okay, thank you. So I'm Dr. Anastasia Irinchi. I'm the Director for Traditional and Alternative Medicine, and I'm so happy to be here today. And I want to thank all the researchers for a very good work done. Can we put our hands together for them? So everything about managing non-communicable disease regarding the integration of herbal medicine is really apt. The time is now. The time to unravel the mystery behind treatment with traditional and alternative medicine is now. Knowledge is power. So for all the research, I won't mention the names of the presenters, but I will just go through about 3 or 4 of them. One important thing that if you really want to succeed in managing non-communicable diseases, the best way to go is about integration. And how can we achieve integration if the people don't have knowledge? One, I would suggest that we have to include traditional and alternative medicine curriculum in our health education or professional education. We can even start right from secondary level, so that as they grow, they get the understanding, they get the knowledge, they acquire it, and it will help everybody along the line. Number 2, apart from acquiring the knowledge, our education to the public. Most people are saying, right, even from the very high top of professionals, we never knew, we don't understand what is this about policy integration. I have people who sit in the same ministry, they don't even know what is going on. So I think ECI, that is education, communication, and information, is very key that we need to strengthen. And then number 3, one of the speakers talked about reviewing the policy. It's very, very important. The policy on traditional medicine was formulated since 2005. And we have now initiated the process of reviewing. So I think when it is done, so many things will be in alignment. And so we want to talk about that one. And then integration. How do we bring both the orthodox and the herbal medicine practitioners or the traditional medicine practitioners together on the same table so they can understand? So this push and pull system will not help us. Where one is condemning the other, when one is also condemning, it will not help anybody, because the orthodox are always in a hurry to push sicknesses or outcome of diseases or whatever to herbal medicine. Herbal medicine will also, it is the orthodox, you are giving us the problems and all that. And so I think we need to come together and sit on one table to dialogue. Let's understand each other. So that system is fine. I remember WAHU, that is West African Health Organization, has something that they used to do. It's only about 2 years they haven't done it. That's Congress. When they talk about Congress, they bring orthodox practitioners and the traditional medicine practitioners together for about 3 or 1 week conference where they are making presentations, scientific presentations, for them to understand that the herbal medicine is not what we think. There is something that we can offer, especially managing non-communicable diseases. There is a lot. How do we combine or integrate? Can somebody on orthodox treatment or managing NCD, can the same person be on herbal medicine? Which kind of herbal medicine can help? And all these things, we need to look at it. For integration, yes, the inclusion of the recommended herbal medicines list. We have the list, we have reviewed the list, and the only thing is for us to include it onto the National Health Insurance list, because we have done a comprehensive evaluation on the policy of integration. And all the indicators that we used pointed to the fact that there's the need to scale up. But the issue is that the availability of medications, yes, but assessing the medication, no, because the Southern people were able to purchase cash and carry. Why is it that we are all contributing towards the National Health Insurance? And if I want the option of herbal medicine or traditional medicine, when I get to the pharmacy, I have to pay. So all these things are the gaps, the cracks there that we need to look at. I won't take much of your time, but I want to say congratulations to the team. Thank you.
Thank you very much. I want to remind us that there's a whole session where we are going to talk about what are the interventions we need. So if you can make your interventions a bit high level at this particular discussion so that we can get more people contributing to the discussion, it will be very helpful. Thank you very much. Okay, I have this hand up. So I assume that is a contribution, so it doesn't demand an answer. Yes.
Yeah, okay. Samuel Hene is my name. My question goes to the presenter who talked about, or should I say, who made a great suggestion that it should be possible for people to get care for different NCDs at the same facility. Specifically, say if you have a mental health problem and say hypertension, after you've been seen for hypertension, there's no point referring you to another facility. My question is, did you find that there was capacity at these facilities to be able to deal with, say, the mental health problems? I thought that the reason they were referred was because there was no capacity.
Can we take the other person on that table so that then we will let them answer and then we can save some time? Yes.
Good morning. My name is Ajwa Kusitre. Mine is not a question, it's a comment. I want to say that the presentation was great as well as the work. So my comment is that we know that for most conditions, there are psychosocial interventions to it, which I think are often ignored at service delivery points. And by evidence, we also know that quite a number of patients with NCD have mental health issues, about a third, commonly depression and anxiety. And I think that oftentimes because the psychosocial aspect is missing, which the work showed that they are usually working in silos and there's that lack of integration. So things like being supportive, being empathetic, being non-judgmental, while providing service, speaking well to the patients and communicating effectively are all important aspects of service delivery, which goes a long way to impact on the mental well-being of the patients and improve the outcomes. And sometimes it may just have to do with understanding the context the patient is coming from, and moving away from that paternalistic approach of providing service where we are forcing interventions on patients. Patients do not understand this. They have their own belief systems and culture. And I think that from the findings, and particularly with the alternate treatments aspects, and we could also look at the psychosocial aspects, because I think that's when it comes to a lot of the traditional treatments, they do extremely well with the psychosocial aspects and its impacts on the outcomes, particularly for NCDs. I think when it comes to those treatments, it's an active ingredient. So even for the orthodox treatments, if we are able to focus on some of these things, it will really go a long way to improve the outcome of patients. Thank you.
Thank you very much. I think I will allow the team to respond to that question and maybe comment briefly on the psychosocial. Please let them use. Could you give it to them? I think it's Lucy, yeah.
Thank you, Prof. Ohene. So my suggestion was the integration of the various providers, mental health and hypertension and diabetes. You are right. When we went there, the mental health unit, they had only community psychiatry nurses. They were dealing with the basic management of persons with mental health conditions. When they had challenges, they called the doctors, a particular doctor who was interested in mental health condition. They called the person and then they always are not sure. Is this, is that, is that? And so one day when they went, they said, oh, you people are doctors. How are you going to help us? I hear you have a team of doctors in addition to you. So how are you going to help us? So they wanted some, maybe psychiatry, thought we had psychiatrists or psychologists amongst us who wanted to support them. Then the doctors are just young doctors who are general practitioners. So now we also had to say that, okay, when I come to the region, I know a lot of the psychiatrists and the psychologists, we can talk to them who can help with their skills issues. So they, at a basic level, they are able to do that. But when it comes a little bit difficult, then they want to refer. And so they were asking us to bring them psychiatrists or a psychologist as part of the team to support. But I said, I know others who they can consult on phone to help them, but it never happened.
Okay, so any comment from the team on the psychosocial support? Any brief comment?
The psychosocial support, they actually didn't have any of them. The only thing they did was once in a while, they brought in some NGOs, supported them with a family day or family and clients day, and that is it.
Okay. Okay, so any other, I think we'll come to you first and then you, and then we'll come back to that table.
Let me also just respond to Prof. Ohene's question on the integration. Yeah, I think I also mentioned that. And actually, you are very right that at that level, we don't have the capacity. Much as some people made that suggestion that it should be possible for us or somebody with comorbidities, maybe hypertension or diabetes and mental health, to be able to get the same attending physician attend to him or her. Yes, so it came up, but other stakeholders also, just as you said, the issue of capacity and whether or not some of those diagnoses can be made at that level, at the level of maybe health center, whether conditions associated with mental health can be made at that level and whether they have the capacity to give prescription. So it was actually something that we also took notice of, the fact that there is no capacity, and even our health system, whether it's positioned to be able to have that kind of integration, was an issue that others were concerned about. Thank you very much.
Okay, I think Prof. Irene wants to comment on the same thing. Yeah.
Okay, sorry. I was saying that part of the essence of the co-design process is that we are actually here to now get understanding of what we have found and ideas as to how to go forward. So I would suggest that some of the comments that come don't need an answer. They just need tabling. If I can give an example, is it possible to have one-stop care for all these NCD? I would flag it as something that should go into a co-design forum. We don't need to feel that the research team must provide an answer here and now. Similarly, the psychosocial elements of care are missing. I would again think that if there's a question, it is that does the data contradict it? If the data supports it, again, I would send it into a co-design discussion. So I'm just encouraging us not to get stuck on feeling we have to provide an answer to everything. Thank you very much.
Yeah. So it's more of listening than doing anything. Yes.
Thank you for the presentation. Yes, I've been wondering whether I should comment or not, but then from NHIS. Yes, NCDs is really important to NHIS, I would say, because I would say about 10% of our reimbursement is only for hypertension and diabetes. 10%, which is very significant. And we looked at our data and we also realized that most of the hypertensive cases, we are losing them to follow-ups. And that is an area that we probably may need research into to find out why the patients are being lost to follow-up. Is it that the alternative medicine that is coming in is what is taking up the patients? Or what are the nitty-gritties in there? Is it that our treatment is not functioning, or there's some issues there? Yes. Again, we also want, though patients are receiving treatment, data available also shows that just a little over 10% are having control of their hypertension disease. So again, can we look at what are the issues that are not aiding in controls so that we can improve in that aspect? A lot of comments about NHIS reimbursement and other things are also playing a role, as is being said. But I would say that for some time now, reimbursement has greatly improved. So that shouldn't be a major challenge in terms of facilities providing medications to patients. I would say that patients, per NHIS policy, chronic patients can receive medications for a period of 3 months, and they are all reimbursable. So I heard in the presentation that they only give 1 month, and then subsequently they're supposed to pay. No, it's in the policy, 3 months subscription, prescription is issued and it's reimbursable. So these are some of the, yes, there might be a lot of education that needs to go in there, I agree. But then sometimes we as prescribers and health facilities, we also need to
help the system, in the sense that we all know that health insurance deals with generic medications. However, as a form of maybe revenue generation and all that, and maybe perception, there's a notion out there that health insurance medications are not good in terms of quality because they are generics. Because maybe our interest is to raise revenue for the facility, we intend to stock branded medications, and that would be sold to the patients. So some of these things are also contributory factors by some of us, the prescribers and health care managers. So in that regards, I would also entreat that we all pay attention to that aspect as well. Thank you.
Thank you very much. I think that is very useful in terms of health insurance. There's somebody on the line we will go to before we come back into the room. One of the issues I guess you need to think about and maybe respond later is the issue of the levels where these diseases can be diagnosed and treated, so that you probably contribute to the discourse on what is the real policy concerning that, in terms of at what level can these diseases be diagnosed and managed. So that's something we want you to comment on later on. So let's go to the person who is, well, you read it. Okay, read it. And please let us know who is asking the question.
Okay. So this is from Remy Songti. Thank you for such a wonderful presentation. I'd like to find out if there would be interventions in place to engage our media personnel in their propagation of some herbal without the necessary checks as to whether these medicines are approved by the FDA or not. Thank you.
Okay, so that's a quick. You want to address it? There's another one. Okay, take that other one.
Hello. Yes. So this is from Victoria Bayo. I suggest we pay particular attention to the concurrent use of herbal preparation in addition to the ones prescribed from the hospital. Yeah.
Okay, so that we saw, isn't it, in the lived experiences and the journey. And she's saying we should pay attention in whatever interventions we are doing to the concurrent use of the medicines because of interactions and other things which we well know, which the patient may not know about or be aware of. So that's a suggestion. So it's something to take note of. I had a lot of hands in the room. Hey, please alert me in terms of time. Okay, so when just because this makes that we are all very interested in this. I think I said I'll come to you, then I'll come back to you because you had your hand on. Then I'll come here. So let's take note of that. Can we make our comments a bit brief? So we'll go to him first.
Okay, thank you so much for the presentation. You guys have actually made me mix my day in academia. Now, we saw a whole lot of gaps and opportunities at the primary healthcare level. Some of the facilities are taken up on NCD diagnosis and management. And I've had several engagements with my man here from NHIA. And when it comes to these facilities taking up on some of these things, there is a big policy gap. If the policy does not give them the right to do some of these things, NHIS will not reimburse them, then the patient will have to bear the financial cost. So I want to know, in this study, are you looking at policy feasibility, policy review? Is there an opportunity to do some of this review? Because Ghana is looking at 2030 to achieve universal health coverage. How are we capturing that opportunity to make the necessary reviews? Because I know currently there is a whole lot of policies which are being reviewed with respect to the primary healthcare facility. Are we identifying some of these policies within this research and seeing how we can make sure that some of these policies capture some of the key things we actually see in this research that we need at the primary healthcare facility. Thank you.
Thank you. We will go to, yes, he had his hand up a long time ago. Yes. And then I'll come. And this particular question, I will let Professor Irene comment on briefly later on when we have picked all the questions.
Thank you. I have about 6 questions, but because Prof said at the co-creation,
Yes,
there will be a
so
lot of.
if you can just.
So I'm limiting it to 2. The first one is the primary healthcare service assessment, availability assessment. I want to find out why, I mean, when it comes to NCDs, particularly diabetes and then hypertension, studies have shown the community pharmacies remain the first point of call for most people. In terms of monitoring, I mean, when they are stabilized, they go to the hospital and they are stabilized, they come back into their homes. Monitoring, a lot is done in the pharmacies. And somebody mentioned that a lot of them are lost to follow up. So what is happening is that a lot of them are actually going back into the community pharmacy. They just take the package of the medications and walk into the pharmacies and continue the treatment. How are we, is there a reason why this particular assessment study did not look at the potentials of integrating the community pharmacies into this treatment? And then the second question would be on the availability of essential medicines. Is it, I thought as a country, we are doing better. I mean, that's my thought than what I'm seeing here. Is it a case that maybe the legal scope does not allow certain facilities to stock beyond certain essential medication? Did we align the medications that we are looking for with the legal or with the policy that each facility is allowed to stock? Right. Thank you.
I hope you've taken note of these 2 questions. Then let's come to. We want to take a round and
Yeah.
then because of time.
Yeah, thank you. From sitting down from the presentations, it's very clear that in policy, we talk of people-centered care. But the findings still points out to the fact that we are professionally focused care. We don't see the person as a whole. Because unless we look at that critically and we actually make professionals see the person as a whole, because once you see the person as a whole, you will see the relevance of the other people that the person goes to. The second point is integration. But please, integration means different things to different people. It is very important. And therefore, during the co-creation, this should be discussed seriously so that we have a common understanding of integration. I think that's okay. Thank you.
Yes, please have a hand up, and then I'll go to Director of Public Health. Yes.
Yeah, thank you very much. And then good work done, the team who carried out the research. The first point I want to make is giving patients 1 month, especially the diabetics, the hypertensive patients, could be a strategy by the institutions, because there are instances where they have only very little amount to be able to procure the drugs. So when they buy the drugs, it will not be prudent to give 3 months to a number of people and others will not get. So the way is to give 1 month so that everybody can get, hoping that monies will come and they'll be able to buy and continue. So it goes back to what we have been saying. Director said health reimbursement has improved. Yes, that could be true. But how improved is it? Is this solving the financial needs of the institutions. So we have to look at that angle. The second point I want to raise is we must go back to the basis, traditional medicine and then orthodox medicine. That tension between the two professionals is something that needs to be dealt with. Why am I saying so? Sometimes you have the patient taking herbal medicine and within her body, she feels fine. Then he goes to the orthodox practitioner, and then the orthodox practitioner begins to condemn the usage of herbal medicine. Now, it makes the patient confused. Do these people really want my welfare? Do they really understand what they are saying? I must be quick to add that some of the herbal preparations are not the best, because the advert will tell you one drug can cure hernia, piles, and fibroid. It is clear that that cannot be true because the various pathology differs. So you can use one single drug to be able to do that. So let's iron the rough edges between traditional medicine and orthodox medicine, and we'll be good to go. Thank you.
That's three. And if we can make our interventions brief, then we can.
Yes, thank you very much. Let me say that I want to commend the team for the very good job done. I mean, please let's clap for the team. Because NCDs is on the radar, and the idea is that how do we get it done? So I just have some few comments. One challenge we have is the burden of NCDs in the country itself. People go to chemical sellers and community pharmacists. How do we get the data? So I want to see how the team can guide us. How do we get the data to be sure that this is the burden of, let's say, NCDs or hypertension in the country? We've just done our step survey, but I think that it would be good that as a country, we have a better idea of the nominal figures so that we can be sure how we are going. Then I think that about the Sarah tool, you make mention of diagnosis capacity at the CHIPS level. I don't know what we are diagnosing at that CHIPS level. So if the team can give us more explanation what they are diagnosing at that low level. And it also made mention of the use of essential medicines. So what are they using at that level with respect to NCD? If you can get some clarity. But I think that one thing I want to suggest is that, you see, Ghana, the very common disease condition is malaria. And everyone knows that malaria can be cured 3 days. So the thinking is that if you are sick, you can be cured. So the mentality for it to be lifelong does not exist. And I think that's one big challenge we need to be able to see how you can convert the average Ghanaian to appreciate that there's a disease that it has not end. And then I think the last thing is, how do we get people from the onset, from the educational level, very early age, to appreciate the concept of NCDs? Thank you very much.
Thank you very much. That's the Director of Public Health. So what we are doing sits right on your laps. So we are happy you are here.
Yeah, thank you very much. Very good survey. I want to find out, or let me say, I want to state that orthodox medicine, and the alternate medicine, that's the traditional or the herbal, exist within our facilities. Some facilities, we have a point where if you need herbal medicine, you are directed and you go there and you have the medicine. But my challenge is how to regulate the herbal space, herbal medicine space. What is the efficacy of what they are actually, supplying or providing outside the facility? What kind of clinical trials have been conducted? What is the dosing? And what are the drug-drug interactions, between the orthodox and the herbal medicine? I think we need to look at that space very well. Then we can actually do detailed integration, because you go to one place and they give you gallons of herbal preparation to take. Take 2 cups, 3 cups a day. How sure are we that the dosage, is right? And its toxic effects on the body is also measured. Thank you.
Okay, so I'll crave your indulgence to do the last one here. We will have the other session where we will contribute further because we need to look at our time. Otherwise, we'll run out of it.
Thank you very much for this opportunity. My name is Sandra Sean. I work at Lekma Hospital and I'm the president for the Ghana Association of Medical Herbalists. I think my colleague was made mention of the elephant in the room. I'm a medical herbalist. One who asks who is a medical herbalist, and we have 55 medical government hospitals that herbal medicines have been integrated, and the herbal physicians who are handling these herbal units are the medical herbalists. So I've been working with Lekma Hospital as a herbal physician, or maybe you can say a medical herbalist. Thank you. I want to ask the case study of the gas out, that's the case study. How many did you engage medical herbalists, and how many medical herbalists did you engage? Because I realized with regards to your presentation, it seems both indigenous herbal practitioners and medical herbalists probably all being clumped into one basket. But I want to clarify that the medical herbalist acts as an intermediary, or let me say as a bridge between indigenous herbal practitioners and also the allopathic doctors. So with regards to interprofessional relationship, especially at Lekma Hospital, we are doing so well when it comes to the management of NCDs because we work closely with the physician specialist clinic. And we have some fundamentals. One, someone walks into the herbal unit to assess or for treatment or management of NCDs. We request at least your 3 basic chemistry labs, that is the BE, LFT, and lipids, before we even start any treatment. I know most of my colleagues in the other Ghana Health Service facilities are doing so well with that. And in terms with regards to regulation and all that, I would say in Africa, I think my boss has said, Dr. Anastasia has said extensively, in Africa, when it comes to integration and regulation, Ghana has really been a pace setter when it comes to herbal medicines. So my question is, I want to find out maybe probably some medical herbalists he engaged, but I didn't really hear anything of that sort in his presentation.
I think we will stop here. There are 3 questions that will be answered, and then Prof. Irene will comment on the policy issue, and then we will bring this session to a close. Like I mentioned, we have another session where we can engage further. So the questions are, did the study look at the community pharmacists and their role and the availability of essential medicines? Were these calibrated by level? Then this question about, did we engage medical herbalists? If we can answer those 3 very quickly, then I'll ask Prof. Irene to comment on whether we are looking at policy review. Okay, so who will answer from the presenters? The community pharmacists. You do that, okay.
We engage community pharmacists in our data collection. So we went to a number of them. Some of them can dispense prescribed drugs, hypertension, drugs for NCDs. Mental health, no. So those who are allowed to prescribe, they do. Those who are not allowed, they tell us they do not. But as we did the participatory video, we engaged a woman with hypertension in Ghana South. And one of the community pharmacists will be there so many times. Do you prescribe? No. And when we allowed the woman to go and film herself in the community pharmacy, then the person who is not allowed to dispense that drug brought that drug out. So it takes a lot of time and effort to discover some of these things. Those who are allowed, they do it, but those who are not allowed is the issue. And in Adan, which wasn't a case study, we realized that
Very brief, Lucy.
yes, the Adan, they went to the shrines and the prayer camps. All right. And they also added whatever they are supposed, not only the herbs, but orthodox medicines.
But I think the question she's asking is about the medical herbalists.
No,
those who operate. So can we answer that question?
Yeah, okay, thank you very much. So in actual fact, we did engage medical herbalists. In Gar South, we engaged the local herbal medicine practitioners, but we had to engage the medical herbalists out of Gar South because it wasn't something that we could find at the facility, that's from Polyclinic. So yes, we did engage medical herbalists.
So
Thank
I
you.
think that's good. So the last one that I want Irene to comment on is a question on, are we thinking of a policy review? Policymakers are here. Are we thinking of policy review and influencing it in any way?
The simple answer is it is necessary. So the answer is yes. Our findings show there's a need for policy review, like has come out in this room. In fact, people got very nervous. I said this is a consortium with London School, Burkina. They were, well, how can you affect policy review? Researchers don't change it. And our response was, it has to come from the co-design. We all have to sit around the table and talk and talk and talk. And if it's agreeable in evaluating the intervention, we'll have to need special permission that maybe in a district or two, can we pilot that if you review certain policies, does it make a change? Do you get better adherence? Do the costs come down? But it cannot be done without a dialogue. So that's why we are here co-designing. Thank you.
Thank you. Thank you very much. So thank you very much. We have looked at various issues which we will be discussing further. One of these is the policy issues. One of these is whether different stakeholders have been engaged sufficiently in their role. A key thing that has come up is integration, the need for integration between the alternative medicine and orthodox medicine, realizing that the people are, there's just one person, they tend to go in all the direction. How do we streamline and make sure that the going into all these directions does not in the end become harmful to the patient? And then we have looked at issues have come up on the data on NCD burden, the diagnostic capacity at various levels, and importantly, the paradigm shift in the thinking of patients about the chronicity or otherwise of NCDs. And then issues with yes, prescriptions, NHI issues have come up strongly, and we are very happy you are here to put things clearly so that we see how the policy that is there on paper can translate into reality in the health facilities. So thank you very much. I think you've ended your coffee break. We will discuss some more. There's a lot more to discuss. Thank you very much.
Thank you very much, Prof. So we'll be going for a coffee break, 30 minutes. So it's 11:40 now. So by 12:10, everybody will be expected here. Thank you. And please, just outside here.
as
Can we all kindly come in? Okay. Okay, so we are about starting the next session, and it's going to be moderated by Professors Angela Osuansa and Professor Samuel Ohening. Can you kindly give a round of applause?
Okay, welcome back from the break. We intend to keep strictly to time, so please be advised. The first, well, this is supposed to be a presentation, and later on we'll have a discussion on the potential shape of the current interventions that we're doing. And the first speaker is Dr. Elizabeth Awini. She has 20 minutes to tell us about what we have learned from the Response Project, mental health screening to support decision-making and care at primary health care level for NCDs. Dr. Elizabeth Awini. Oh, okay. Well, I'm told that she's not here, so Dr. Levina will take her place. All right.
So good afternoon and welcome back from the break. Right. So I'm happy to share one of the projects that was led by Prof. Ejapong, of which I was part, called the Response Project. So the Response Project is actually a project that aimed to understand systems responsiveness to the needs of pregnant and postpartum women, which included adolescents with mental health problems or mental health conditions in Ghana and Vietnam. And we co-produced with key stakeholders, which included clients, their families, communities, frontline health providers, and policymakers, and also have done a formative evaluation of the intervention to improve responsiveness. So in principle, we had a need to address maternal mental health conditions among pregnant and postpartum women. And we looked at available tools that we could use at primary health care level for assessing the mental health of pregnant and postpartum women to address this huge gap. And so we fell on one of many tools called the SRQ20 self-reporting questionnaire, 20 item. This is a WHO tool that has a number of questions, simply responding to a yes and no question, and then it assesses your level of distress. And I want to stress that it's assessing your level of distress. It does not give a diagnosis. And so we set our cutoff for this project to getting a score of 6 and above as being in a certain level of distress. So the higher the scores, the higher the level of distress that an individual is reported to have. For this, we converted this questionnaire into an electronic version on Kobo Collect. The need for that was to ensure that even if you don't have internet access, you can administer the questionnaire electronically, and then it will be uploaded online to a source where it is monitored. If you do not agree to participate, it ends, but consent is sought even on the electronic questionnaire for you to ensure that you agree to participate in that interview or project or assessment. And so I would like to kind of give you the opportunity of experiencing firsthand what it looks like to take this assessment for yourself. And then we will have a discussion following your experiences, and then we'll show you a video of the impact of the pilot study we did and how the recipients, one of the recipients of this intervention, evaluated the intervention and her feedback, as well as the healthcare professionals who administered the intervention, their feedback and how it affected their work in their clinics. So at this point, in the interest of time, I would encourage that you ensure that you have a smartphone. Unfortunately, I won't work this time. So I hope that everybody has a smartphone, and ensure you have internet access and you can scan a QR code. And this will be our QR code. We will assist those who are not able to maneuver the technology. And then we would ask you to go through the survey, answer yes or no to the questions on the questionnaire. At the end of it, you will see your own score. It is for your eyes only. So you appraise yourself where you stand. And then we'll have a discussion following that. Thank you. Please, if you need any assistance, my colleague Wanda is available to support. I believe Dr. Kusitre would also be able to support if we have a challenge. Yeah, that crack ships. The W. You can actually. And then the purpose will be routine wellness checkup. So we've received 4 responses. About 38 more of us to complete. Thank you. So please, in about 2 minutes, would like to end, and then we would take a few feedback, and then we would share a video, and we can conclude. Okay, so thank you very much. Any feedback? Did the scores scare us? Or we are okay? So if you scored anything 6 and above, you are in some level of distress. But that is not to tell you that you have A, B, or C. A further assessment is required to understand what exactly you are going through and how best to help you address it. Please, can we have feedback from at least 1 or 2 people on their experiences?
I just had a few concerns with some of the way some of the questions were formulated. I think question 7, for example, if you are giving this survey to, let's say, a lay person who's not a hair professional, and they say, have you had indigestion or something like that, or something like that? And then there was also one question, I think question 13, suffering something that it wasn't clear to me, or I feel it will not be clear to a lot of people. And the question was in a negative sense, are you not unable, something like that? I was not too sure what. And then I also suggest that the 0 and 1 instruction should probably be at the top of each page. I don't know if you got the 0 means no, and then 1 means yes, should be on top of, since the questions come page by page, so that it constantly reminds you that 1 means yeah. Thank you. I'm just trying to see the question as simple as
The standardized.
the healthcare professional.
It's a big word.
Okay, so my question is that if you ask me, have I had indigestion? If I am a layperson, how do I know if I've had indigestion?
Indigestion.
Yes. So there was another question later that spoke about having some discomfort or something like that in the stomach. I felt that one was better. I don't know if the aim was to corroborate the earlier one or something. There was a second question like that along the way.
Mine is a follow-up to his 1 and 0. It gets confused. I don't know what app it is and if it will be changed. If you can just see the 0, the yes, and then no there, and have the 1 and the 0 coded in the background. Because I'm like, is it 1?
Yes,
is it 0?
yes.
Is it yeah, just yes, no. Otherwise, some of the answers.
Thank you very much. So these are standardized tools, not just externally, but it's been used in Ghana, but was among pregnant women, postpartum women in the northern part of the country, and it has been standardized as and validated, and so can be used in general health care. It's not specific to any particular setting. So it can be used as a routine screening tool to identify people with distress. And based on further assessment, you're able to help them identify what the challenges are and how to help them. So this is what we used in the maternal mental health project to screen pregnant and postpartum women, after which if they met the criteria for distress, they were further engaged by the nurses, trying to find out where the stresses are coming from, whether it is at home, within the relationship, or etc. And were provided basic psychosocial support, counseling. And sometimes just listening to them was enough to allay their fears and improve their well-being. And so this is what we used to support the women in the project, better able to go through their pregnancy and postpartum period successfully. And so I would like to show a video that encapsulates all that in a minute and a half. Yes, Prof wants to come in.
0 and the 1. In fact, in the setting in which we use this, it's a rural setting. Many clients were illiterate. It was the nurses who were administering the tool with their phone and their tablets. So for them, the 0 and the 1 was not a problem. It can be coded in the background, but that's really the context in which it was used. Many clients just said, please do it for me, period. If you wanted to, you could do it yourself, but many of them, yeah.
It's okay to put it at the beginning of every page. I mean, maybe some people, after the first instruction, they couldn't remember. So that one does not do any. It's just a reminder. So that can be done. Yes. Yes. So every question will put 0, no, 1, yes. You know, that's okay.
Thank you very much. So we invite you to share the learnings from the project in this video. Thank you.
Esther, she is a teenager. We didn't see her during antenatal, but we just saw her at child welfare clinic. Fortunately or unfortunately, that day when she came, they took her through the too, and they realized, as for her, her score was very bad. He started talking to her. She started crying. In a point in time, she preferred dying than being in the world. So we have to take her through the psycho education.
Bene jamani me yano Can you scale no like ibeje no poor alo ki jeje no mi ijeju ku me he poor sena mo buy.
She got pregnant at age 15 and she stayed with the mother and the stepdad. So the stepdad was angry initially, but get to a point it's like it has happened. So they are trying to come on settlement that he stay in the house. Then the second pregnancy also came. The stepdad said no, she can't be in the house and be giving birth to both of the children, no responsible father.
I think that we had technical challenge. In the link. Yes. Thank you very much. Hope we stay with it.
Good afternoon. The next session has to deal with a tool, a technological tool that is being piloted, is in the process of being developed to help with both identifying certain, let me just be clear on what I'm saying. Identifying risks is a risk assessment tool and a decision-making tool that will help either the medical team members to help identify any assistance they can give to the patients or being used by the patient themselves. So the gentleman who has designed it, David, is going to kind of illustrate how it works for our input in terms of how usable it is. So thank you.
Yes. Hello, everyone. Please, can everyone hear me? Okay, can I please start my presentation? Okay. So my name is David Sasu, and just for context, I'm a computer scientist, and I'm finishing up my PhD in computer science, specializing in AI. I'm also a machine learning researcher at Apple, and today I'll be talking about a technological intervention that I'm developing to help with the Stop-Ncd project. To give context, there are definitely a lot of people who do not have NCDs who would most likely go on to develop NCDs in the future. On a personal note, I have a mom who is suffering from hypertension, and I also have an aunt who is suffering from diabetes. And before they actually contracted these diseases, they contracted them fairly young. They showed no signs of actually contracting these diseases until they actually went on to get them. And I'm pretty sure there are definitely people in the audience right now who know somebody who is suffering from these conditions who didn't used to have them before. So this technological intervention tool that we are proposing is going to be a mobile app that can help people to infer their risk of getting these conditions so that they can engage in the behaviors that would most likely dramatically reduce their risk of getting these conditions before they get them. Because we all understand that these conditions are chronic in nature. And once somebody gets them, they spend their lifetime managing it. So if we can introduce tools that can help people to reduce their risk of getting these conditions, then it's incredibly beneficial. This tool that we have developed is going to be disseminated at the community level for people who have smartphones so that they would be able to go through the application and answer all of the questions that the application will pose to them so that they can infer their risk. And the application will give them personalized recommendations of things to do on a daily basis to reduce their risk. In many ways, it's similar to the tool that was presented before, but in also many ways, it's also incredibly different because this tool is being powered by an AI model on the back end, which is going to be adapting itself on the basis of who is using the application. So I'm just going to show a short video to demonstrate how this application works. So we are calling the application Lynette, and the application is still in its development phase. I'm going to be pausing the video at different points in time to just talk through the different functionalities as and when they are displayed to sort of explain what is going on. So this application is designed primarily for smartphone users, and it is primarily designed to be disseminated at a community level for people who would want to know their risk of getting the NCDs of interest. So somebody starts off by downloading the application and then answering all of the information that the application is requiring so that they can set up in the application. Now, you would observe that there are different kinds of general information that the application asks to help the AI model to decide who it is talking to and how to even ask the questions that it is going to ask. So it's not a static tool like the tool that was presented before, where you have, specific questions that have been hand-coded into the application. But this is a very dynamic tool where on the back end, the AI itself is going to determine how to even phrase the questions to the person who is using the application on the basis of the information that the person provides when they are signing up into the application. So let me continue. So over here, the person provides information that they are an electrician. So the AI model knows that, it's talking to somebody with some fair amount of literacy and technical training. So it will take all of those things into consideration. Okay, so at this particular portion of the application, Let me just forward it. The application is asking for which specific NCDs that the person using the app would want to track for or would want to assess their risk for, whether it is hypertension, diabetes, or anxiety, given the fact that we are interested in hypertension, diabetes, and common mental health care conditions, such as anxiety. Okay, so this screen just loads up. And on the background, what is happening is that the AI model is taking all of these things into consideration to prepare the questions to ask the person. So it's beginning with a hypertension questionnaire. So over here, it's fashioning all of these questions. Over here is 10 very simple questions that it's going to ask the person for the person to fill either on a yes or no basis or to provide more contextual information on. So questions such as, do you often drink alcohol? How many days per week do you engage in physical activity? Have you smoked before? Or have you smoked? Or are you currently smoking? These are all basic questions that the application is going to ask. And after the application asks all of these questions, it gets to this particular screen where it demonstrates the person's risk on the basis of the answers that the person has provided of getting a specific condition, which in this case is hypertension. The person can click on this tile to get a more detailed breakdown of all of the contributing factors, as you can see over here, that the mobile application took into consideration to assess the person's risk. And there's even a part of the application where the person can ask more in-depth questions, and the AI model is going to answer the person's questions, of course, with validated links and referrals to medical personnel as well. Let me just forward it. So after the mobile application has inferred the person's risk, what it does is that it then generates personalized recommendations to the person on the basis of their risk of getting the condition. So over here, it's generating these three recommendations to the person, to take a 15-minute walk. And if the person wants to read more about why the mobile application it's recommending these specific personalized recommendations, they can click on the specific recommendation to read about why the model is recommending this and even see links to different articles, research papers that they can read to get a better understanding of why that specific recommendation might be useful to them in particular. Sorry. Just fast forward it. Okay, so sorry. So they get to this specific part of the application where it's this AI model that is hyper specialized on non-communicable diseases. So what we did when we're building this AI is that we took an open source, top of the line, state of the art medical AI, and then we trained this AI to read thousands of peer-reviewed research papers on non-communicable diseases. So what we've effectively done is that we have created this superhuman expert in non-communicable diseases that can answer people's questions regarding their condition that they are being assessed for or any other conditions that they might have. Sorry. Yeah, so there's a portion where they can ask for anything. So I'm just going to pause over here. So what this is a daily tracker where every single day for some specific number of days, the model is going to propose plans for every single day for the person to follow. And then what happens is that at the end of the specified number of days, the application would give the person a follow-up questionnaire to assess the person's progress and to reassess the person's risk. The model that we have trained, the AI that we've trained, we've given it one job and one job only. And its job is to ensure that the person's risk for getting whichever condition that they are tracking for is absolutely low. So what the AI is going to do is that on the basis of, the follow-up questionnaires that you answer, it's going to readjust the plans that it gives you to ensure that your risk of getting the condition is as low as possible. Yes, so this is just an overview of the application, and its use case is really going to be in the community level, where we would really want to provide a way of preventing people who are on their way to get these conditions, preventing them from getting these conditions by introducing a technological intervention that can help. So this is just an overview of how the whole application works behind the hood. I'm not going to go into the technical details, but just as an overview, how it works is that we have this medical AI, and what we've done is that we've got thousands of research papers, peer-reviewed published research papers from very quality journals on non-communicable diseases. And what we've done is that we fed all of these things into this AI, and then we instructed the AI to go through it to extract all of the non-invasive risk factors for assessing non-communicable diseases. So the AI itself read all of these papers, and then what it did was that it then took out, all of the important risk factors and crafted risk assessment questions. So the AI does that on the basis of whoever is using the application. It adapts the questions to them. And after the person presents their answers, to this AI, the AI takes all of those things into consideration. It takes every single thing it knows about non-communicable diseases that it has read, and it also takes into consideration who exactly is using the application, where they live, what their age is, what their occupation is, and then it gives them a personalized plan that they can follow for some specific number of days to reduce their risk of getting a non-communicable disease. So I'm just going to stop over here and then just open up the floor for any questions that anybody else might have. Thank you so much.
Okay, thank you very much.
No questions. Okay. Any questions for David, please?
Yes, thank you very much, David. Great tool you are developing. I just want to find out, you indicated that you have fed it with some number of articles, peer review articles. What is the period that you picked these articles from? And then will it be able to recognize future articles and recommendations that are coming up that probably might be different from the ones that have been fed into it? Thank you.
Yes, thank you so much. So this is a wonderful question. So what we did was that to set up the initial development of the application, we got thousands of research papers over the past 5 years for non-communicable diseases. And what we've done is that we've also really connected the AI to the back end of the online repositories where these papers are published from. So every single time there's a new paper published on a specific non-communicable disease of interest, what would happen is that the AI will download this paper and it will go through it. It will actually read it to get the important information that it needs to update its own knowledge. So even the risk factors that the AI will take into consideration to formulate the risk assessment questions will change on the basis of current research. So that's how it works behind the hood.
Okay. Thank you, David, for this innovative work. My concern is the limitation that, of course, you've shown us. You mentioned that, of course, the focus is around hypertension, mental health, and anxiety. could you expand it, make it like other NCDs? I know the focus is not only on these three. If we
Yeah.
can add other NCDs, of course, sort of those interested in other form of NCDs when they actually come on board, or maybe they feed in information, they also get the needed desired response. Thank you.
Yes, thank you so much for your question. So that's the innovative part of the application, and that's the scalable part of it. Because the application itself is so dynamic, the AI that we have, so far as we feed it research papers or peer-reviewed published research, and even any data really on, well, verified data on non-communicable diseases, it can really adapt itself to whichever non-communicable disease we are interested in. And that's the different thing with these kinds of intelligent software tools. They are not static. They are incredibly dynamic, and they will adapt on the basis of what we need from them. So yes, it's possible to do that. Thank you.
All right, David, thank you. Next question is for me. You mentioned this is tailored towards a community, so it's a community level.
Yes.
But it's really in the English language. So who are the target groups that you
Yes.
the app is for? Thank
Yeah.
you.
Thank you so much. So as we are developing the pilot of the application, really the pilot of the application currently is for people within the urban areas who have smartphones. I mean, of course, the core innovation over here is this AI that we have trained to read all of this information. And of course, once we pilot the application and it proves to be successful, we can definitely adapt it to other low resource contexts, and not necessarily just focus on urban areas. So thankfully, these days, there have been major advances in speech translation and even speech and even text to speech kinds of systems where you have people who can actually talk to intelligent systems these days, and the systems actually understand and respond in whichever language that you are interested in. My research in my PhD is focused on developing intelligent systems for low resource African languages. So it's not as difficult as you might think to really adapt these technologies to really fit in the context of our own local languages for people who do not have smartphones, to use it and also get the benefits from that as well. But for this pilot, we are starting with building it for people in urban areas with smartphones so that we can work out the kinks and develop it and ensure that it's pristine enough for other areas. Thank you.
If I may just add on to what David said about the languages, and as he said, his PhD is on natural language processing, and he's already started work with Tree and Hausa. He found a font of words using translated Bibles and hymn books and so on. So he's already working on that, not specifically for this, but just to say that it's one of the next steps should he pilot it and get the results he's looking for.
So mine is a comment. I really loved the emojis on the app. Just to say that young people are healthiest, but it's during our young lives that we accumulate a lot of risk factors because we seem healthy. And for this app to appeal to the young audience, I think you should add a lot more visuals, color, pop-ups to appeal to the young audience.
Yes, thank you so much. I think so. So that was one of the reasons why we added all of these animations. I think when I was talking to the user experience designer who designed the interface, he also made this comment as well, and that's why he included all of these, animations over here. I was thinking that it makes the application a little bit childish, but he pointed out the point you're making as well, and I think you are both absolutely right. And I think that there's also research that's stating that, people are more likely to use applications, especially those in the younger demographic, if the applications are gamified in a way. So if we can provide a way of making it fun in a gamified way to live a healthy life by following all of these, personalized healthcare recommendations, we can really end up with a generation of people who have as low risk as possible of getting a non-communicable disease. So thank you so much for your suggestion. I think you're absolutely right.
Okay. Thank you very much. I really like this innovation. The first one is, so I'm leading a project in the Upper East and Upper West where we are looking at cardiovascular and psychosocial risk assessment, especially in women of reproductive age. I hope we can use your tool for me. The second question is that how does the data that you fed into the AI take into account individual variations? This data is more like aggregate statistical level data, and sometimes there are individual variations in the way some of these cardiovascular issues manifest. Does the data is it able to capture people with peculiar rare issues like that? Thank you.
Yes, thank you so much. To answer your first comment, definitely the idea is to definitely open source the application and make it available for anybody to use worldwide, really. So you can definitely deploy it for your own setting once we test it and release it. But with regards to your second question, whether the model is able to capture these nuances, the short answer is yes. And the reason for that is that, it's not just about the NCD research papers that we are feeding into the model, but the model itself on the base level is, so this Meditron that you see over here, it's a very, very large medical language model that has been trained not just on literature, but it has also been trained on patient records and medical images and clinical guidelines. So it's been trained on a lot of information. So what we are doing is that we are taking this base model and then we are fine-tuning it for NCDs. So the model already has all of this contextual information embedded inside its knowledge base. So the short answer is yes, it can definitely capture these nuances within reason.
I think we can go online now. Or did you have someone else, please? Oh, please go ahead.
So, yeah, David, Sami, my
Hello.
question is about the question that relates to alcohol.
Yes.
I heard something like, do you often drink alcohol? I'm wondering whether that is not too vague to be able to elicit a reasonable response, as well as from both the person taking the test and from your from the AI, whatever it is.
Yeah.
Understand me that does the literature differentiate between somebody, say, who drinks a bottle of beer once a week and somebody who drinks 2 shots of whiskey every day?
Yeah.
In terms of the risks. And then when you ask the question, do you often drink? How would the person interpret it? I'm just wondering whether it would make any difference if that was made a bit more specific.
Yes, I think you're absolutely right. So with regards to these models, on the back end, I could definitely prompt the model to drill down on for each question have like a theme, and then really drill down asking specific questions to get more information from the person. But I think the model, I intentionally prompted the model to ask these questions because we also didn't want the model to generate like 50 or 100 questions for somebody to answer. Definitely, if you give more information, the risk becomes more and more approximate to the truth. But, also from a user standpoint, you have to do this fine balance thing where you have to ask so that you'll be able to get just enough information to give, a ballpark, just enough risk assessment. So you're absolutely right. Definitely the questions could be more precise, and we could definitely ask more follow-up questions. But I think that, we will definitely have to really figure out the balance of how to get as much information we want without necessarily also asking the person a lot of questions to bring user fatigue when they're using the application. But I think you're absolutely right. I'll think more about that. Thank you so much.
So we'll go. Oh, okay. Please go ahead then.
Risk. What's next? Are there recommendations proposed by the AI as according to your level of risk? That's my question. Thank you.
Yes, please. So in the application, once your risk is assessed, oh dear, so sorry. Once your level of risk is assessed, the idea is that the application, firstly, to give you this interface where if you have more questions to ask regarding your specific risk, you can do that. And then what it does is that it proposes a personalized plan on the basis of your profile when you are signing up into the application. It proposes a personalized plan for you to follow on a daily basis for some specific amount of time. And then what happens is that after that time has elapsed, the model, gives you, a fresh questionnaire to answer where it's trying to gauge whether your risk has gotten better or whether your risk is still the same. And what it would do is that it would alter the plan that it gives you on the basis of the follow-up assessments that you do. So it's really designing this continual loop where the person keeps on using the application, and if they follow the recommendations, they on a long enough timeline continually reduce their risk of getting an NCD. Thank you.
Okay, thank you so much. There are some questions online. I'm assuming this is one of them, so forgive me for reading, but just so that we can get to the end together. Please, it will be very important to strengthen community engagement and involvement with multidisciplinary healthcare team approach in the management of NCDs. Each facility must have protocols that are, that's not the question. It's not for David. So where? Okay. I was wondering what it was. Okay, thank you. So does the application have a voice prompt? And what are the data privacy and ethical issues embedded in the app? What does the application do with data that it gathers?
Okay. Thank you so much, Prof. Angela. So let me take the first question with regards to the voice prompts. When we're designing the initial pilot of the application, that was also something that one of the engineers that I'm working with and the designer raised for us to include voice prompts. I specifically pushed back against it, primarily because one, it definitely increases the complexity of the implementation. And I mean, given that, I work with speech myself, I know how complex it can be because for speech, you have to take so many things into consideration. Things like background noise, accented speech, all of these are a can of worms, especially for, healthcare tools that you really don't want to get into. So the idea was to design something that was as simple as possible to start off with, where we could really test out the effectiveness of the core idea for the application. Definitely, if the application does, succeed and gives us beneficial results and outcomes, then we can definitely think about, okay, how do we design this to include people using their voice in a way that, leads to better outcomes, better and improved outcomes. So that's definitely something we think about. But I generally don't think that it's something that we should think about now, because really the most important thing right now is really testing out the core idea at this piloting stage. And also the second question that had to do with where exactly all of the data is going. I'm really glad this person asked this question. So the nice thing about the application and all of these models and every single thing that we are doing is that all of the models that we're using are completely open source, and I'm hosting them myself on my own private server. So all of the data that people provide, that's where it goes. The idea is that once we successfully pilot it, I can have a discussion with all of the people that are the lead PIs in the Stop-Ncd project, and then we can decide together what will make the most amount of sense with regards to where all of this information goes. One thing we can do is that we can decide to just encrypt all of this information, and then just lock it away somewhere so that nobody has access to it. But also another thing that we could decide to do is that we could anonymize the information and then use it for other public health research needs. So that's definitely a conversation that will be had in the future. But currently, all of the information would be going to my private server where I'm hosting the application. Of course, this would change in the future when the application goes live for the general public, because where I'm hosting the application might change. But currently, with regards to the current design, everything goes up onto my own private server. Yeah, thank you.
So we're rounding up now. All right. Okay. If nobody has any more questions. Oh, okay. One more question and then we'll round up.
Thank you. Please, I wanted to find out if I understood, you're now about piloting. So is there a reference risk assessment tool that you are using to compare something that has already been validated? You're going to compare it to say that yes, this actually predicts risk.
Yes. So thank you so much for asking this question. I had a slide that I took out because of time, but it was a slide containing the research that was the inspiration behind this intervention. So just last year in September, I think 23rd September 2024, there was a group of medical personnel at the University of Pittsburgh who piloted, deploying this same architecture, but for COVID-19 risk assessment. And it was incredibly successful, and they wrote a whole research paper about it. Fast forward this year in the literature, there are a lot more hospitals, particularly in US and also in China, who are also using this same approach for risk assessment in different contexts. So this is definitely something that's being done in the developed world. That hasn't yet been tried in the developing world, in the developing setting. So, it's definitely something interesting that we could try on our end and pilot it to see if it works for us in our context. But to support this point, with regards to the question of whether machine learning has been used to assess risk in sub-Saharan Africa and in developing countries historically, the answer is yes. So it's just that machine learning hasn't been deployed in this fashion where we are using these, language models. But historically, there have been other kinds of machine learning algorithms that people have deployed in different sub-Saharan African countries to infer risk. And I worked together with a couple of researchers on the Ashesi team to write a couple of scoping reviews where we actually reviewed a couple of papers talking about different instances where different machine learning algorithms had been leveraged for risk assessment. So this is definitely something that's not new. It's definitely something that is done. It's just that, using large language models in this sense, which is the current trend, it's being implemented in the developed world. It just hasn't yet been implemented in our context. So this piloting stage of the application is to see if it would work for us in our context. Thank you so much for bringing that up.
Okay, I think we're going to round up. just as a quick point of interest, David has shared how inadvertently, through some of the work he's done, he's been able to, through voice, even though he's not using voice now and will use voice later, that using voice, his algorithms can determine level of stress, even just from the voice alone, which is yet another aspect of the stages and the steps for producing this. So thank you so much. I'm going to hand it over back to Prof. Ohene.
Well, thank you very much, David.
Thank you
I'm
so
sure
much.
that the feedback was useful. Thank you very, very much. We are very happy that you're here. So the next stage or the next part of the program has got to do with review and discussions to work towards consensus. No, we're going down on in the shape of the intervention. So we're going to have groups, about 6 people per group, I believe. And this will be moderated by Professor Irene Ajipong. I believe you will distribute them into groups. And we'll have 20 minutes. Please, let's try and keep to the time. After that, we'll have a feedback session much longer, so we will take the questions and answers.
Thank you very much. In fact, because we are moving into co-designing interventions, what we want to do is, you've all heard from all that has been found. You've heard the questions, the discussions. We now want to think together a bit that going forward, what should be done if we want to pilot, evaluate interventions for effectiveness, for cost. What should our priorities be? Are there issues that we think are really pressing? And also, some of the issues have come up. Maybe there are issues are the instructions clear? And we can't have more than 6 to 8 people around the table. So what we'll suggest is the tables that already have about 5 people already the beginning of a group. If you're on a 1, 2, 3-man table, please find a bigger group to align with. I think that will save people from. The only thing is, I will disrupt this table. It's all GCPS researchers. Please redistribute yourself. The other tables, I think, are a bit more balanced. Am I right? And each of you around this table, please help with the reporting in your group, the note taking. So I'll give everybody a few minutes to just move. So we have this is a 1, 2. This is a table. This is a table. This is a table. This is a table. All the tables at the back, you are too few to form a table, and this is a table. Okay. I think this is also another table. So if you count and they are not up to 6 to 8, you can join them. 6, you can join them. I think so. And please, the GCPS reporters, make the list of who is in your group and the notes from that group. Okay. And each table can designate their own chair. We've helped you with a reporter, but the chair. Okay, thank you. So we'll reconvene in 20 minutes, which is at 13:36. Thank you.
Hello. I'm so sorry. This is to our online audience. So we are also enabling the breakout rooms, and you can join and also partake in the discussions. Thank you. Yes, so you can type your ideas or discuss. You get one person to be the reporter and then type the ideas back in the chat box. Thank you very much. Okay, so the rooms are open now and you can join any room. So it can be about 10, 20 in a room. Thank you.
Yeah, hello. Please, can I call us back into plenary so that we can present the ideas that came up around our tables? We'll give each group 5 minutes to present the ideas that came up around your table. It's almost 2 o'clock, so we do need to move along. So this is your 1 minute warning. In another minute, I'm going to start group 1, group 2, group 3, group 4, group 5.
Study medicine system also help catch people who like the software and stuff, just like the technological interventions can also help catch people at their own set the condition. I think. Okay. Yeah.
Intervention to check data collection, the role of able to quality level by having that data for the information. If you have more data, how this is the role of the pharmaceutical.
Like that. There may be advocacy, but it's not very easy to change policies.
So don't capture it that way.
The NHIS, they have facility issues, right? But their policy, they will tell you that they cover all this. Then if you zero down to some facilities, they are not actually going by. So it has to do with implementation adherence, facility level. There are some medications that they fully cover, but if you go to facilities, you find that either they are doing top-up payments or they are even charging. So that is not the
Okay, so I'll invite table 1. This is table 1, table 2, table 3, table 4, table 5. So we'll invite table 1 to just summarize for us the issues you've come out with. The reporters will bring their notes, so that's fine. Just summarize for us quickly. Thank you. So table 1, the floor is yours. When you finish, just pass the microphone to table 2.
Thank you very much. So at table 1, we were 9 members, and we had a community council registration rep, a dietitian from the Ministry of Health, researchers from the Dodua Health Research Center, as well as some of the research team members on the Stop-Ncd. So some of the interventions we came up with was to allow for task shifting at the health center levels for the nutritionist, to allow them to be able to better manage patients with NCDs, even though their general training doesn't allow them to give specific diets for patients with NCDs. If we encourage task shifting, we can train them to be able to help patients with NCDs. And we also talked about policy advocacy for the NHIS reimbursements to be quicker, so that the community pharmacists will be able to give medications to patients who come to buy from them. So because currently it's not, the reimbursements are so slow, most of them are not taking the NHIS. But if they improve that, more patients will have access to medications. We also talked about implementation challenges. Yes. So we also talked about interventions to improve the policy by allowing more pharmacists to be able to use to be able to work to their maximum. So currently the community pharmacists play a very important role in the community. They are able to screen patients, they're able to refer patients to the facility. Some of them in an emergency situation can even give medications for patients with very high blood pressures, etc. And so if we improve on their services by encouraging them in the form of remunerations, and also in allowing them to be able to work effectively by creating good communication between them and the primary health care, we'll be able to improve patient care in the community. We also talked about the screening of patients with diabetes. So currently, most facilities, if you go and try to screen for diabetes, they'll charge you a small fee to be able to pay for the test strips that they use. But then currently in the policy, NHIS policy, those are supposed to be covered as well. But because of challenges with implementation of those policies, sometimes the facilities charge a small fee to be able to keep buying the diabetes strips. And so it'll be very important for us to look at implementation adherence at the facility level for some of these policies. We also suggest that the NHIA look at some preventative services. So currently, from what we've discussed, it's in the works to include some preventative services such as screening for pre-diabetes or patient education, that's the wellness clinics, to allow more patients to be able to prevent the NCD before it happens, rather than just paying for treatment, that's medications, after the patient has gotten the NCD. And so we just want to encourage that as well. And we also mentioned task shifting for physician assistants to prescribe antihypertensives at the lower level. Since most of them are the ones who be at the health centers where most patients would have access to. And we also mentioned that currently there's a network of practice that's being encouraged for patients to be able to be seen in the lower level without being referred to a higher level. So if the PA at the lower level, let's say the health center, is able to manage the patients, then they don't need to be referring the patients to the higher levels, which has its challenges. And this is currently being implemented. And so it would be good for us to back it up for that to happen as well. And periodically, we suggest that doctors come to the patients at the lower levels rather than the patients being referred constantly to the tertiary levels. And that way, you encourage that network of practice where patients are seen in a particular community by the same practitioners, and it'll be easier also to manage them. And then finally, we also talked about the app that we discussed earlier and how beneficial it is in helping patients to assess their risk. And so we encourage the use of the apps at the lower level as well, and for the app to be able to allow for referrals. Sorry. Okay, thank you.
Thank you very much. We'll hear all the tables, then we'll see where the commonalities and contrasts are. Thank you.
Good afternoon. For group 2, we looked at two main gaps. The first was access to care of NCDs at the primary healthcare level. And the second was integration and collaboration between orthodox and alternative medicine practitioners. So with the access to care of NCDs at the primary healthcare level, we broke it into two groups. The first was looking at it at the geographic level, so increasing access at the geographic level, and then increasing access at the financial level. With the geographic level, the overall theme was that we needed to strengthen the health facilities in remote areas to reduce the referral burden. And we identified 4 ways in which this could occur. So the first was the idea of a mobile clinic that can come into smaller communities. And it didn't have to be anything very huge, but it could be as simple as having medical personnel from higher level facilities coming regularly into remote areas. And they could also help train the community people and help with medicine dispensation. But for this, based on the current policies that are available, they would have to apply for approval prior for medical dispensation once a specialist is coming in. We also mentioned that these mobile clinics could take different forms. So for example, it could even be like a bicycle. It could be adapted to many different communities depending on what a mobile clinic will best be suited for them. The second way to strengthen health facilities was through remote consultation, for example, using telemedicine. So if you have a smartphone or a phone in general, you are able to call a physician or somebody in another area who could help. But this is dependent on a person having a device. The third was for dispensation of medication to remote areas, drone machinery could be used, and the example of Zipline was mentioned, which already does this. And the fourth was making sure we recommend policy reviews to the Ministry of Health to look at the policies regarding the different levels of care at the different health facility levels and what they are enabled to diagnose and the medicines that they can disperse and if they can be reviewed to empower those at the lower level. Then in terms of the financial level, we are looking at modification of NHIS policies to increase financial access. But then we also realize that some of the financial burdens come from hidden costs, like the transportation cost that comes with referrals. For systems integration, we acknowledge that there's ongoing integration with regional hospitals and medical herbalists. Currently, there are 55 medical herbalists in Ghana, and they tend to operate within the district level. What we do recommend is having regular forums between the orthodox and traditional practitioners, especially so that they know what the traditional practitioners do and understand. And one of the issues that was raised was that there are some traditional practitioners who are not trained with the local medicines. And so even identifying these people can be quite hard as well. And then we had a two-pronged approach in that the first is to get the medicines. We decided that we will be able to have the herbal medicines within the mobile clinics, and that included a two-pronged approach. So getting the medicines within the NHIA, covered by the NHIS, and then also getting these herbal medicines within the NCD approved medical list, because currently the NHIA does not have any registered herbal medicine. So those were the suggestions we came up with.
Just a quick one to add. I think we actually looked at 4 main issues, but because of time, we couldn't exhaust the last 2. So the other one was the issue of quality assurance. So we're looking at the branded medicines as against generic, to the need for us to kind of dispel misconceptions around patients who think NHS medicines are not quality enough and all that. Then on the issue of collaboration between service providers, researchers, and policymakers, we think that enough is not being done in that area. There's a need for us to bring all these groups together to the table to discuss and find out how they can work together to improve services for NCDs.
being undertaken currently. And that can influence the way we can improve human resource availability. We also talked about medical outreaches, and if we want to undertake any form of outreach, we can actually petition the NHIA, and the representative actually said a maximum of 1 month we can have a response from them to be able to allow us to roll out certain specialists and people who can perform certain activities in certain levels of care so that we can actually gather some evidence to be able to encourage if we need to do any policy reform. And then we talked about the other aspects of care, not being just pharmacological, but also lifestyle. So we mentioned that in terms of the community, we need to engage them in their lifestyle, their habits, also road networks, also street lights. We can actually look at having some interventions in those areas. And then we noted that for telemedicine, remote diagnosis, NHIA is already doing certain work there, and we had information coming out that they are going to move further in what they are doing to see how they can use telemedicine to improve non-communicable disease care. In terms, it's all boiling down to the human resource availability. Then, in terms of quality of care, there was a question about should there be a research into why there's improvement in the capacity to reimburse medicines, especially it's about 18% now, but then why is control still not being achieved? So should we do a research to see what is going on? And one point that came out was that maybe we need to follow up on our patients. And a key point that came through that was, could we have an identity for the people with non-communicable diseases, whereby wherever they go, wherever they travel to, so in the form of a health identity that they can be accessed anywhere that they go. So that would improve, we'll go into the health information systems. So I think that's what I would. Also, we mentioned that in meetings like this, we need to also invite HIFRA because they are important. They are one of the biggest bodies in regulating the facilities in terms of what they can provide and what they cannot provide, the services they can provide. So thank you.
Okay, please. One small thing was also mentioned. For the health information systems, it was also mentioned that we do not have an NCD register across the various levels of care. So it will be important to introduce this particular register to aid especially with the follow-up of our clients at the various levels of care. Thank you.
Group 5, then the 2 groups online have typed out their, so we'll just project what they typed out. So group 5.
Hello, thank you. So with group 5, we also touched on policy review that yes, it should be looked at. There should be some changes or an amendment. And then also with the policy review, there should be a focus to at the alternative medicine. We also touched on task shifting, that there should be capacity building, and then the task shifting should be with supervision, and it should be managed with monitoring and evaluation components. We also talked about NCD programming, that there are a lot of conditions when it comes to NCD, so it makes it difficult. So therefore, there should be some specific NCDs that we should look at that should be addressed. We also spoke of disease burden of NCD, that there is a gap with surveillance. So we need to know the data with regards to the burden of NCD, which can also aid us in financial support, getting financial support for NCD issues. Another thing we touched on was community pharmacists. We noticed that they were mentioned throughout in our presentations. However, a lot of NCD data we have does not capture them. So if there are ways, there could be a linkage between community pharmacist data and then integrating that into the database we already have. And with the database to NGOs and CSOs have data. So we are also we touched on how to capture their data as well, and then not just capturing them, but linking the people they've already found to care. We spoke about getting dedicated fund for mental health, that indeed the Mental Health Act captures funding, but then the sources haven't been determined in the act. So if there could be a focus on that aspect. And then we mentioned that there should be an economic evaluation in every evaluation that is being conducted. And also, we touched on data systems. So we wanted to find out what are the data that is already existing and that is covering hypertension, diabetes, and mental health. And it was mentioned that although the data coverage is available, the reliability is the problem in the sense that patients go to different points of care. So sometimes they are duplicating our data. And so with that, we mentioned there should be a robust NCD data surveillance. And then when it comes to the supply chain system, it needs to be strengthened, and then essential medicine should be available. So with that, we asked ourselves, is it possible for CHIPS to administer drugs? And then what is going to be the implication for NHIS? We also mentioned on using experiences from other conditions from TB. So with TB, patients are given numbers or specific ID. So if the same can be implicated for NCD patients, so that when they go to different facilities, it will be easy to identify them. We also spoke about linking the NHIS with Ghana card so that it's easy to get information on everyone. Once that is done, every condition you need on the patient will be easy to access. We also spoke about looking at the whole picture holistically when it comes to solving issues for NCDs. So it should be solved, we should look at it holistically and then try to solve it systematically instead of the short gaps that we normally do. An example of Australia, Australia uses community pharmacy in their care and they are well regulated. So if we can touch on their experience and see how we can implicate that in Ghana too, that will be helpful. And someone also raised a suggestion on looking at these three conditions, that's cancer, hypertension, and diabetes, that they all have similar risk factors. So if these three conditions can be touched together and then mental health added in addition, that one too will be helpful. Finally, we spoke about awareness creation and increased education, where an example of HIV/AIDS was cited that when we were young, there were a lot of communication on HIV/AIDS. So if the same can be done for the conditions we are looking at, if there's a lot of awareness creation and education on that too, that should help. And then we also looked at further research on drug development when it comes to herbal medicines for NCD. So if there could be further research done on drug development for NCDs. also education of traditional herbalists. So there should be more education for the traditional herbalists when it comes to the NCD condition. And then we also mentioned that normally when it comes to NCD, we look at the community level, but then when we go to the corporate institution, most of the people in the corporate institution, they live a sedentary lifestyle. And if we can also look at that direction, it will be helpful. And I have a few points to go. So when it comes to alternative medicine for mental health, there was some recommendation made like massage therapy and acupuncture. So if we can use those ones for treatment of mild mental health conditions like anxiety and insomnia. So if we can research more into that area. And we also spoke about integrated care. That is the healthcare providers working together and then making easy dissemination of information amongst themselves. And finally, we spoke about researching more into the gaps that we have mentioned throughout our findings, and then also looking at loss to follow up issues. So if there are interventions that can help to curb loss to follow up, that would be helpful. Thank you.
Thank you so much. So I think yes. So the online inputs. I think. So please, can we scroll down to breakout room 1? Digital health tools, train health workers on digital app use, optimize user functionality, enable supervisory oversight, combat health misinformation. That's very useful. Is there more? Okay. Okay, so that's the sum from the online group. That's all. Okay, so if you can download it, we'll add it to the notes. Thank you very much. So at this point, we are more or less drawing to a close. I'm sure you've got lunch coupons. It's a sign that we are drawing to a close. What Prof. Ansa and I did is we formed a group where we took the notes from the morning discussions and then the inputs from the presentations to try and at least quickly rough and ready synthesis of what is emerging, put together in one document. It has to be tidied up and we have to add the notes from all the groups. But at least we think it's a good way to sum this morning that we'll just present those slides. Then what we'll do is we'll take all your notes from the groups. We will triangulate them. We'll do some small qualitative analysis so that where the same issue is being repeated in a certain group, we just flag the issue, period. So I will just have the list of issues and then we'll sit down and think through it a bit. Some of the issues don't need research. They just need administrative intervention. Some of the issues also, we really don't know what will solve the problem. They probably need research to test solutions. So we'll separate it out. And then we will have a final dialogue before we move towards piloting, because the way we'll go about this is we will pilot the interventions that need research evaluation. Initially, what is working, why is it working, how is it working? And then then we will, before we pass the intervention through what is called an effectiveness assessment, that will then provide maximal usefulness to the health sector. Please. So that's the way forward. So we hope that when you hear from us again, you'll be as kind as you've been today to come and think with us. And we'll also try to be responsive. If we are not being responsive, please let us know. Because at the end of the day, this is applied research. It's supposed to make a difference to Ghana. It's not just supposed to end up with publications in peer-reviewed journals. Thank you. So I'll hand over to Prof. Ansa.
Thank you very much, Irene. So I'm going to be quick and give us an overview of what we've tried to pull together. So this is a synthesis of emerging ideas on the intervention, possible intervention package. So if you go to the next slide, this project is related to SDG target 3.4, which is on non-communicable diseases and mental health. And the aim is to reduce by 1/3 premature mortality from non-communicable disease through prevention and treatment and promote mental health and well-being. So mainly to make sure that people live healthy lives and improve access to healthcare for these people. So the source of the ideas for the intervention package have been from scoping reviews, which you heard, primary data collection from the SARA and the case studies, co-production, fora with different groupings, and then today's meeting. So today's meeting will become part of what we are doing. So the early part has gone in, but what you've done just now is not in it. So if you look at it, just to give an overview of the categories of cross-cutting interventions from the different methods, on my right-hand side, yes, here on my right, I don't think this is working. No, go back to the diagram. Or am I? Okay. So patient and community educational empowerment interventions. And this includes risk assessment and the counseling tool. You know, the tool that was presented by David. So this will be one aspect of it. Then access to referral and specialist professionals, like we had dietitians, physicians, psychiatrists from the presentations that were done. And then PHC access and quality of medicines and services. This includes integrated approaches and task shifting. And then policy and systems changes required to enable these interventions. These are the broad categories that we have had. So I'll quickly go over the different areas, what we've captured so far. So if you go to the first one, which is the patient and community level intervention, there the main intervention we've captured so far is this personalized risk assessment tool that uses the Lynette app that David presented. And if it's made, it's likely we are aiming that it to be made available through Google Play Store and through Apple, so that people can access it and assess themselves. He said so earlier on. And then some patient intervention, educational interventions at the OPD. Then when you come to the facility level interventions we've captured so far, it includes a package of tools, systems, and policies, mainly to improve access to primary health care for people living with these conditions. So issues that have come up relate to approaches to enable a one-stop shop care for all the 3 NCDs. Psychosocial aspects of the care has come up very strongly, and we've captured that. Then addressing loss to follow-up of cases that have been diagnosed came up as we discussed. And we are hoping that we'll be able to achieve this kind of care through supporting and enabling non-physician frontline health workers to screen, assess risk, make initial diagnosis, make clinical management and referral decisions. And we are hoping that we will be able to support them to provide follow-up, monitoring and follow-up with physician support and specialist support. So that's what, so before this is done, there will be some activities that will need to be done, such as identifying and modifying certain clinical decision-making support tools, adapting simplified guidelines and simplifying guidelines so that they can use these, and even adapting these for tablet-based algorithms for decision-making and referrals to physicians by the non-physician frontline health workers. We have to agree on which health providers should be doing this, which category and why. So we've put that down for us to discuss going forward. And then a development of a risk assessment, diagnostic and management guidelines for these non-physician primary health care workers and nurses. And also design or specialist outreach clinics. How do we do this? And what will it entail? So the actual interventions we envisage at this point will include training the frontline health workers in using these guidelines, making the guidelines available through tablets, through mobile phones, task shifting activities, along with periodic, people talked about supervision, periodic physician or specialist review and management. So all of these issues we've talked about, and then implementing physician and specialist outreach clinic. And at this point, we are envisaging that this would entail the physician or the specialist coming to the primary care facility periodically to provide specialist care. And this will need health, the NHI involvement in shaping this and allowing this to happen. And then engaging the community pharmacists seems to be a very important thing we have captured. Then when you come to systems and policy level interventions, we see from all our discussions that health system supports to the non-physician frontline health workers have to be enabled and tested in intervention test setting to see whether this will work. And if it works, then the health system may have to then engage in a policy change to make a difference. So we may have to set a system of testing this under special dispensation to see whether it works and what the impact or the outcome will be. And then we can engage in policy change. So some of these include modification of the prescribing policy. For instance, at what level can non-physicians prescribe hypertensive, antihypertensive and manage diabetes? This has to be agreed on. This is something that may need to be tested and may need a policy change. Then we have talked about the traditional, complementary, and alternative medicine policy and practice, how this relates to orthodox medicine care. This needs to be looked at. Then facilitating adherence to the policy for NCDs at health facility level. An example is this 3-month patient refill. The actual street level practice is that we do 1 month. How can we facilitate adherence to this policy? Screening for diabetes, we heard over here that people have to pay for it, but the thinking is that people should not pay for it. How can we ensure adherence to this at the health facility level? So these are components that will need policy modification if the intervention is proven effective. And the research will focus on testing effectiveness. So we'll request permission to create those if conditions. And then if we generate evidence, then we can then discuss at national level and see how this will work. So certain issues we want to consider, which we want to bring to your mind. The intervention package will need to be tested or piloted both in rural and urban settings to learn the lessons, because these settings they tend to be different in many ways. So we will be thinking about that. And then linking this to the networks of practice policy seems to be something that is going to be very important because of the referrals we are thinking about. So all of these need to be thought about in the package. And then improving access to essential equipment and supplies. We saw it in the presentation. This seems to be key. But at this point, we are not proposing it to be part of the intervention because it has cost implications and sustainability implications. We are assuming at this point the system will provide this, but this is something we need to think about. So by way of next steps, we will sit together, reconcile some of the issues that have been raised here with what was distilled from the data that has been collected and presented so well. That reconciled intervention package will be reviewed, applying the lens of its evaluability and whether expected outcome measures are measurable. Because if we can't measure the outcome, then we can't say anything about it. And then the final revised package will be piloted in collaboration with stakeholders and further fine-tuned and tested following the pilot implementation. But before we do the pilot implementation, we will organize a final stakeholder consultation to validate that final package that we have distilled from all that has happened here now and what we distilled in the morning. So thank you very much.
Thank you very much. We are all tired. We are hungry. We've worked very hard. But just in case, are there any pressing, burning questions? Otherwise, we have all your email addresses. We are going to stay in contact. We'll share progress notes. And like I said, we will invite you back again before we start the pilot. Regional Director, Eastern Region and Greater Accra will talk with you more because by all means, we'll pilot in your territory. But that one will. So is there any burning question? Otherwise, yeah.
I have one issue. I hope I'm not throwing a spanner in the works. We started off by defining co-production from point of view of the research group as working with the stakeholders. And in fact, the primary group we identified were the user population. And then, of course, we've added policymakers and the people who are here. But in this meeting, I don't see any of the user population. And we are talking of a final stakeholders meeting. I don't see them reflected.
It's a very good point, and it's deliberate. We did that because of the power differentials. Our observation is that sometimes when you put community people and people they see as big people in one room, and they see you all as big people, people may not really fully express their minds. So I mentioned that before we came to see you, we've actually been talking. We've been to Afram Plains North, Dunkok Room. We've talked at facility level, at community level. We've been to Adan East. Hey, I said Gan East. Ga South and Adan district. Again, and in fact, the videos you saw, for example, come from some of our community level engagements. We were just very cautious about putting everybody in one room. Then some people will just keep quiet and look up to you because you are the ones who know. That's all that is happening right now. They're fine. And in fact, we were going to go back to them, whether we should now invite them to join the big people up here in the final forum. I'm still not sure because I still worry about the power issues. I still worry a bit about the power issues. I've been in forums where everybody sits down and says nothing. Then when you go to visit them in the community, they tell you that, you know, that thing they were talking there, I don't agree. It's like, but why didn't you say it? Oh, how can I speak in front of all these big people? That's the pure reason.
Yes, Prof. I also have a question. The first one was what Prof just asked. The second one is in terms of the patient and community level interventions. I think we've not really included much. If we are talking about NCDs and early detection, I think the focus should be more on the community. We have patient educational interventions at OPD, but not community educational interventions. I wanted to know if there's a deliberate reason for that. Thank you.
Okay, it's a good question, and if I think you have the answer. There's currently another UK-funded project called Chorus. It's research on urban health. It's actually happening in Ghana, Nigeria, Bangladesh, and Nepal. The Ghana research team is based in the University of Ghana School of Public Health, and they decided to look at urban chips and how to make urban chips take care of life cycle issues. And in their context analysis, what they found is that people see chips as MCH. So they don't bother with chronic illnesses. So the chips intervention one is looking at integrating health education promotion into chips. In fact, they've been doing community education, screening, and so on in Medina Lang, Quantana. That's where the research is ongoing. We had actually wanted to invite them to present here today, but on reflection, we decided we'll use another forum because they have advanced and started the intervention. So that's the reason why we are not talking about those things, because we are fully aware of what is going on there, and we felt it's unnecessary duplication. Yeah. And you are part of that team. You should have just said it. And that's why we invited you here also. So yeah, thank you.
Okay, by way of information, before the last question comes up, on each table, there is a QR code. It's for an evaluation of this co-production process. So when you scan it, it's a very simple tool, about 10 to 15 minutes or less, you should be done. At the end of it, it's on every table. At the end of it, kindly make sure to click on the submit button. If not, all the answers you would have given will not be captured. Thank you.
So we'll give 5 minutes to fill the code, after which we are going for lunch.
Yeah, so thank you very much. I think my question actually relates to the lived experience shared by the patient and the person living with NC, that's diabetes and hypertension. I think, sharing lived experience also bring to fore challenges that patient actually goes through at the community level, especially post-care, what actually happens at home, what they are going through. In fact, I was disturbed as to when she was mentioning that one syringe she used 2 times, 3 times, 4 times for herself. That's self-care management. I think we cannot actually, if we want to address issues of NCD, we cannot actually dissociate self-care at home from it. So what plans, of course, is there any plans to include that self-care patient at home, follow-up and the likes? I think that will, if we have such plans, it will also go a long way to help to improve how patients themselves, of course, take care of themselves when they are being discharged from the hospital. Because I know of a situation whereby someone is not able to manage his stroke well, that led to a second stroke, and of course, subsequently to death. So if we are able to connect that to the holistic approach in dealing with NCD, it will go a long way to address the situation that we are all championing. Thank you.
Any further input while people are filling the forms? Okay, then we'll just give you 5 minutes to just fill these forms for us. Please, we'll be very grateful. Just take 5 minutes and fill the evaluation for us. Then we'll allow Vice Rector to close up. DCPS. We are giving them 5 minutes to fill the form, then we'll allow you to go.
Thank you all for coming. Good afternoon.
there will be